morning, everyone. Welcome to the Centre for Excellence in Rural Sexual Health Professional Development Day. I would like to begin today by acknowledging the traditional owners of the land on which we are all on, wherever we are zooming in from today. I personally would like to acknowledge the Dja Dja Wurrung people, the traditional custodians of the land and water on which I am on here in Bendigo. I pay my respects to their elders past and present, and I would also like to extend that respect to any Indigenous people here with us today. It's wonderful to have so many of you joining us, and we have a great lineup of speakers for you. Our first presenter is Professor Jane Tomnay, the Director at the Centre for Excellence in Rural Sexual Health. Jane will be sharing with us STI epidemiology here in Victoria. Thank you, Jane.
So today I'm going to talk about the epidemiology of notifiable STIs. What we will cover is the epidemiology of those chlamydia, gonorrhea, syphilis and HIV, and touch a little bit on their clinical presentation and treatment, and hopefully some important points to look out for and take-home messages. So I'd like to start by just informing people that, as we all know, most STIs are asymptomatic. So it means that people who have STIs commonly don't have any symptoms. We also know that symptoms are the #1 driver of people into clinical care. So keep that in mind when we're looking at these notifiable diseases, because if they are asymptomatic and we don't have screening programs, then it means that those that we are seeing are either opportunistically screened for or requested as part of a sexual history or a sexual health checkup. So let's start with chlamydia. Chlamydia is the most commonly notified sexually transmissible infection in Australia and indeed in Victoria. What I've done is had a look at data up until 2019. So we had about just over 26,000 cases in 2019, and that was compared to just on 20,000 cases in 2014. So it represented about a 1/3 increase, 31% increase in those 5 years between 2014 and 2019. Obviously, as we all know, in 2020 and in 2021, we were in the COVID-19 pandemic, and we saw people having much less sexual contact with casual partners. And in 2020, there was just short of 20,000 cases notified of chlamydia. So the number of cases reported in 2019 was the highest on annual record. I will, throughout this presentation, really concentrate on 2019, given that 2020 and 2021 are a little, anomalies in the data set that we're looking at. So what's really important for you to see here is what I really want you to concentrate on is this upward surge. So as you can see, since the beginning of this millennia in 2000, we've seen increasing rates of notifiable infections of chlamydia in Victoria. And as you can see, in 2019, there we are at just 26,500 cases. When we have a look at the distribution of those that were notified throughout the state of Victoria, the lighter the blue, the lower the number of notifications, the darker, obviously the higher, and then red shows the very high. As you can see here, when we look at the entire state, only Melbourne is seen as high compared to the other parts of the state. But when I looked at these data in the 2 regions which CERSH cover, that is the northeast region of Victoria and the central northwest, we looked at all those LGAs I looked at that were included in these regions that we cover. So if we look here at this bright red, that's Bendigo, and also look at some of these dark blue where we see Greater Shepparton, and down this side you can see the actual numbers. So in Greater Bendigo there's about 6,500 cases of chlamydia notified, and Greater Shep about 3,500. Just remember that, again, this may be a reflection of people living in these LGAs of having very good access to services, to clinical services, and people who are able to get tested more regularly than others. So I'm very careful when I show epidemiology, particularly when we talk to our city counterparts and we use these data to talk about rates of infection in regional Victoria. I don't think they actually reflect the underlying incidence and prevalence of these infections. And that's namely because we know that access to clinical services can be an issue. So We know that about 4 out of 5 people infected with chlamydia are asymptomatic. And so we must remember that partner notification is really important because the partners are also likely to be unaware of their infection. And we can't tell when we take a test for chlamydia. All we know is that the test is positive. We don't know in which direction the organism has been transmitted. So within a partnership, it's very hard to determine who infected who and vice versa. So when we look at the data, again, for chlamydia, this is a different picture to the rest of the other notifiable STIs and HIV. We see it mostly being transmitted throughout the heterosexual community, and we see about 50-50 men and women. Most of these infections, again, 4 out of 5 in the women are amongst younger women, those of childbearing age between the age of 15 and 29 years. And in men, we see 3/4 of the cases in 15 to 35 years, 34 years. They're slightly older than their female counterparts. So how do we diagnose chlamydia? It's very simple. We all know it's a first void urine for both sexes. We can do a urethral swab in males, and that's only ever done these days is if you're doing a urethral swab for something else that the clinician may order chlamydia testing at the same time. These swabs, vaginal swabs in females and anal swabs in both females and men, can be collected by the patient themselves or by the clinician. Clinicians also collect throat swabs to look for pharyngeal chlamydia when the history indicates that this may have been a risk. So treatment again for chlamydia is very easy. Azithromycin 1 gram, it's a single dose. So it's 2 small tablets the patient swallows and that's it, done and dusted. There's no long course of antibiotics. One of the things to note is that we try to treat the sexual partners as close together as the index patient as you possibly can to prevent reinfection. There are other antibiotics that can be used. They're used less often, but where there's a contraindication for using azithromycin, doxycycline for 7 days can be used. Treatment for chlamydia for women who are pregnant is again azithromycin 1 gram in a single stat dose. We know that it's safe for pregnant women. So the take-home messages when we're looking at chlamydia is that it's very common. It's mostly transmitted through heterosexual sexual contact, mostly affects or infects younger people or younger than me. Most people are asymptomatic. It's very easy to test and it's very easy to treat. But if we don't test or we don't diagnose and chlamydia is left untreated, it can in some cases cause some serious sequelae, particularly in women, things such as PID. So we'll move on to gonorrhea. As you can see, the actual number of cases of gonorrhea, if you remember, chlamydia was about 26,500. We're looking at roughly close to 10,000 cases of gonorrhea in 2019. But that was compared to 3,200 and odd cases in 2014, which was a 300% or a threefold increase in those 5 years between 2014 and 2019. Again, 2020 and 2021, much lower numbers due to the pandemic. The number of cases that were reported in 2019, the 9,740, were the highest on any annual record. Again, let's have a look at the epidemic since 2000, and we see this very, very steep upward curve coming from about 2014 and upwards. And if we think about what was happening in these years, this correlates nicely to more effective treatments for HIV. Again, it's pretty much spread throughout the state. And when we look at our regions again, we see again the highest number in Greater Bendigo. And I suspect that that is some anomaly of the excellent services that are available in Bendigo when we compare them to other parts within our regions that we work, perhaps don't have quite the same access. Again, Greater Shepparton's quite high, looking at 342 cases. And so these are sort of larger regional centres. They probably do more testing as well. So who are the people most likely to be infected with gonorrhea? About 4 out of 5 cases we see in men. So about 20% were notified in 2019 in women, and 3/4 again in men. And why would this be? Let's quickly have a look at the diagnostics for gonorrhea. again, it's a first void urine. They can be tested with chlamydia. So one urine sample can test for both chlamydia and gonorrhea. Again, it's the same methods that we use for testing for chlamydia. We can use urethral swab, patient or clinician collected vaginal and anal swabs for both, for vagina for women and anal sex for both, where the history indicates. And also it's important in gonorrhea transmission that we do test the pharynx for gonorrhea if there's sexual history indicates or there's any other evidence for both sexes. We know that we can treat uncomplicated urethral, cervical, pharyngeal or rectal gonorrhea with ceftriaxone 500 milligrams, which is an intramuscular injection. It's often mixed with a 1% lignocaine, which is a local anesthetic, and often given in conjunction with azithromycin 1 gram as a single dose. I have noted here that we all know that there's lots and lots of issues with multi-drug resistance gonorrhea, and we need to be very careful about the treatments that we use. Again, this is very different picture than chlamydia. Gonorrhea is probably the STI that it's most likely to present with symptoms. So men get a urethritis, which is characterized by a purulent urethral discharge. It's often yellow and very thick. In men who have sex with men, infection of the pharynx and the rectum are very common. Infections of the pharynx are often asymptomatic. Rectal infections are usually asymptomatic, but in a small proportion can cause symptoms such as proctitis, which is inflammation of the anal lining, and may cause anal pain or discharge. In women, they will often get a vaginal discharge. Again, complications in women, if they're not treated, include PID, intermenstrual bleeding or postcoital bleeding. So take-home messages for gonorrhea. We mostly see a transmission of gonorrhea in Victoria and Australia in men who have sex with men. However, we do see gonorrhea in people who are returning from overseas travel. So that's both Australian or international travellers visiting our shores here. We also see it in Aboriginal and Torres Strait Islander populations. More recently, we have seen an increased number of gonorrhea infections in heterosexual women. When I first started working in sexual health some 30 years ago, we very rarely saw gonorrhea in women in this state. But remember, it is very easy to test. It's just a urine test, but it may become very difficult to treat in the future due to antibiotic resistance. And remember, if we don't diagnose, it can cause some serious consequences. So I will move across now to infectious syphilis. So I'm only going to talk about infectious syphilis today in this presentation. So infectious syphilis is syphilis that was acquired within the previous 48 months. So in Victoria, we saw 16,072 cases of infectious syphilis in 2019. And when you compare that to 5 years previous, there were only 654 cases, and that represented about a 1.5-fold increase, 157% over that 5-year period. Again, there was less cases in 2020 due to the COVID-19 pandemic. The number of cases reported in 2019 was the highest on record since epidemiology and notification of syphilis became a legal requirement in Victoria. So again, have a look at this massive upswing in infectious syphilis notifications. This is very reflective of what's going on globally. So we see this pretty much around the developed world. And if you can see, there's smaller numbers than the number of diagnoses of gonorrhea, and definitely about tenfold or even more less than chlamydia. But this is important, even these small number of cases, 1,672 in 2019. Again, we see infectious syphilis throughout the whole of the state and larger numbers in metropolitan Melbourne. Now, this is again a different picture when we have a look at those that are notified by LGA. As you can see, there is a group of notifications here at the highest in the Mildura area, and there were 94 cases notified. Again, Bendigo, we see again showing greater numbers at 77 cases, and then we also see 62 cases in Greater Shepparton and 62 cases in the Macedon Ranges. So who's most likely to be infected? About 1 in 10 of these infections are seen in women. But of those women who are diagnosed with infectious syphilis, 4 out of 5 of those are in women aged 15 to 39 years, and that will be important as we move through the next slides. Again, about 9 out of 10 were notified in men. So there is this other story emerging, and the number of cases in females is important, especially in these women who are of childbearing age. In Victoria, we saw 178 cases of infectious syphilis in women, which were notified in 2019, compared to only 17 cases in women in 2014. So that's a massive increase in those 5 years between 2014 and 2019, and represented a 10-fold increase in that 5-year period. So if we have a look at the number of cases in pregnant women, so the previous slide was all women, this is number of cases in pregnant women in Victoria. So you can see certainly 2019 was a year for concern, with 31 cases of infectious syphilis being picked up in antenatal screening in women who were pregnant. Again, there's still quite a significant number in 2020, 26 cases. Is 26 cases too many? And when we think about being involved in the pandemic at that stage, that's still a large number. So we need to look at congenital syphilis, and this is syphilis that is passed on to the unborn fetus or the baby. So in Victoria, the increase in syphilis cases in women has been accompanied by a total of 9 cases of congenital syphilis. We had 2 in 2017, 2 in 18, 2 in 19, and 3 in 2020. There were 2 cases in total reported between 1991 and 2017. So if you think about that, that's 26 years in Victoria where we only saw 2 cases of congenital syphilis. And yet in the past 4 years, we've seen 9 cases. And of those 9 cases, there were 2 neonatal deaths in both 2018 and 2019. I think this is an absolute tragedy, and particularly in a so-called developed country where we have excellent access to healthcare. So how do we diagnose syphilis? Syphilis can be diagnosed, gold standard in Victoria and Australia is 10 mils of blood in a plain tube. We do also have PCR testing that's available for syphilis in Australia. It's currently still being used in a trial and research phase. It only provides a positive or a negative result for infectious syphilis, and I won't go into the way that infectious syphilis is diagnosed, but when we use the 10 mils of blood in the usual tests, we look at a titer level, and we look at the numbers of on that titer level being increased or decreased depending on how whether the infection is infectious or whether it's being treated. However, this PCR test will be much quicker and will be able to tell us if the person has syphilis or does not have syphilis, infectious syphilis I'm talking about here, but it's not yet available in general practice. But I would say watch this space, and I think that will occur in the next 3 to 4 years. The treatment for syphilis is very easy. For infectious syphilis, we use benzathine penicillin as an intramuscular injection, or procaine penicillin as an intramuscular injection for 10 days in a row. So it's 10 procaine penicillin injections for day 1, 2, 3, 4, and so forth. Through to 10 days. That is the preferred therapy for any patients that might be HIV positive. If patients are allergic to penicillin, there's 2 routes we can use. One is that particularly if the patient is HIV positive, they tend to be hospitalised for a short period of time and try to desensitise the patient to penicillin under hospital conditions, obviously. Otherwise, doxycycline 100 milligrams twice a day for 14 days can be used. This can't be used in women who are pregnant or who are breastfeeding. So about 50% of cases of infectious syphilis are asymptomatic, but in primary syphilis, patients may present with a genital ulcer or a chancre, as we call it, but it is painless. It tends to be non-tender and is usually well-defined in its margins, and it has an indurated base. It may go unnoticed by the patient, especially if it's in a place that they can't see, such as around the anus or on the cervix or in their mouth. That sometimes can be on the skin of the buttocks and so on. Because it's not painful, patients don't necessarily know that it's there, particularly if they can't see it. In secondary syphilis, patients may present with constitutional symptoms such as fever, malaise, headache, and lymphadenopathy, where their lymph glands become swollen. The skin's involved in 9 out of 10 cases, and the rash is usually generalized on the trunk, but also may affect the palms of the hands and the soles of the feet. I remember being taught 25 years ago that if you saw somebody with a rash on the palms of their hands or the soles of their feet, you could almost be guaranteed that it was syphilis, because there's very few other conditions that will cause a rash on the hands, on the palms and the soles. Patients may also have alopecia, so some loss of hair, and may get these warty growths around their anal genital regions. In tertiary syphilis, this is syphilis that goes past 2 years, and that we know if it's untreated, they may get late symptoms and complications in about 1/3 of the cases. Excuse me for a moment. Complications can involve the cardiovascular system and neurological disease. Excuse me. So take-home messages when we look at syphilis is that it's mostly found in men who have sex with men. Again, also people who might travel overseas, Australians who may travel overseas, or overseas travellers who may visit our shores, and Aboriginal and Torres Strait Islander populations. More recently, remember the last 5 years, we've seen an increased number in heterosexual men and women. So it's very important that we think about syphilis when people are caring or looking after pregnant women. It's very easy to test, to treat, and it can cause serious health consequences if it's left undiagnosed. So finally, moving on to HIV. This, as you can see, is a different picture than what we've seen with the STIs. So HIV has been was always sort of on this very slow upward trajectory, but as you can see, we start to see the numbers falling. This is all HIV diagnoses in Victoria between 2000 and 2020. So when we look at incidence of HIV in Victoria, that is HIV that was acquired in the previous 12 months, excuse me. Sorry about that. As you can see, we saw this big upswing up until about 2014, 2015, and now we have started to see the curve come all the way down. Now, incident infections for HIV are diagnosed in 2 ways. The person has acquired the infection within the previous 12 months. So they either have a laboratory confirmed HIV negative test within that 12-month period, or they have a classic seroconversion illness, which is easy to diagnose that the person was most likely infected with HIV within the previous 2 weeks. When we look at HIV again by LGA, mostly centred around metropolitan Melbourne, red dot right there in the middle of Melbourne, but still right across our state. Again, when we look at notified cases by the Hume and the Loddon and Mallee regions, again, Bendigo, you seem to be getting the Guernsey here every time. Shepparton not far behind, with 26. These are very small numbers, so please remember that that's what they are. So the total notification numbers in Victoria have remained fairly constant. Remember, some of these will be, so this 279, we saw this jump up from 218, but these may be people that have been infected for many years but have never had a test. At the end of 2019, it was estimated that there were about 9,250 Victorians who were living with HIV, and 90% of those cases were in men. So again, we know that it's mostly found in men who have sex with men, about 4 out of 5 cases. It's also seen again in OS travellers and partners of people who are arriving from countries of high prevalence. It's very easy to test. In Victoria, we still use 10 mils of blood and Western blot. I was on the HIV testing development guidelines group for the WHO for 2018 and 2019. And we have the latest guidelines now determine that Western blot is not the preferred choice, but PCR testing for HIV is now the gold standard, and that there has been rapidly emerging in the developing world point of care testing, which can use saliva or blood fingerprint. Often those point of care tests are testing for both HIV and syphilis, and this is part of the WHO's plan to eradicate maternal or congenital syphilis and HIV eventually. Don't forget that we've got very good treatment now available. It's affordable and effective if you're living in a country with a health system such as Victoria's or Australia's. And we also have pre-exposure prophylaxis, where a person who feels that they may potentially be exposed to HIV can take HIV antiviral medication before that exposure. We can also have treatment as prevention. So that may be people who feel like they might be regularly exposed to HIV, who are HIV negative, may take anti-HIV drugs through a period of time in their life to prevent them becoming infected. We also know that people who are on treatment, who have an undetectable viral load, are unable to transmit HIV to their sexual partners. So finally, my last slide is just very much reminding you around partner notification. One thing we do know for sure is that you can't have an STI on your own. And remember that partners may be unaware of their infection and then subsequently unknowingly pass it on to any future partner. So thank you very much for your time today for listening, and I'm happy to take any questions. Thank you very much.
Thanks, Jane. Just a reminder that the Q&A function is open. If anyone had any questions that they wanted to ask Jane. It was a very thorough presentation. Thank you, Jane. We did just have one question regarding the slides, whether or not they would be shared.
Happy to share, no problems at all. Excellent.
And it's also been commented that this PD day is being recorded and it will be up on the CERSH website in the next couple of weeks if people want to refer back to it.
Thank you very much. I hope everybody has a fantastic day.
Thanks, Jane. Bye. We're now having a break, which we might need some time to digest all that information that Jane has shared with us, and we'll be returning back here at 10 a.m. Thanks, everyone. Welcome back, everyone. I would like to introduce Helen Ferris, who is the Health Services Program Manager at Women with Disabilities Victoria. She's going to be speaking to us about barriers for women with disabilities and how to access sexual reproductive health services and eliminate barriers. So thank you so much, Helen, for being with us today.
Thank you, and thank you for the invitation to speak to everyone. I hope it's been a great conference so far and that the rest of the day will be enjoyable and productive for you all. And thank you to Joanna, who's going to be helping us sharing with the slides today. So we're on slide 1, if that's okay. And if you're able to confirm, Joanna, that's where we are, that would be wonderful.
Slide 1 is up, Helen.
Beautiful, thank you very much. So as was said, my name is Helen Freris. Very nice to be here. I'm the Health Services Program Manager at Women with Disabilities Victoria, shortened to WDV. My pronouns are she and her, and my background, my qualifications are in social work and community sector management. And like most of the staff at WDV, with a disability, I'm totally blind. So that is who I am. So we're on to now the next slide, slide 2.
Yes, slide 2, acknowledgement of traditional owners is up.
Yes,
Helen.
Thank you. So that's where I'd like to begin, by respectfully acknowledging the people of the Greater Kulin Nation on which I am at the moment, who are the traditional custodians of the land and the waters. I'd like to acknowledge the traditional custodians of land and waters where everyone is today across Victoria and possibly even beyond. So I'd like to pay my respects to elders past and present and emerging. And I acknowledge that the land on which we're meeting is sovereign land that's never been ceded. I would also like to acknowledge that Aboriginal and Torres Strait Islander women are 35% more likely to be hospitalised due to violence than non-Aboriginal Australian women. And I think that's important to raise. So if we move on to the next slide about who Women with Disabilities Victoria is.
Third slide's up, Helen.
Thank you. WDV is the peak organisation for women with disabilities in Victoria. So we're a not-for-profit organisation. We're run by and for women with disabilities. And our website is also there, and you're very welcome to access our website at any time. There's lots of resources and information about what we do. So moving on to the next slide and what we're going to be hearing about today. I'm going to try and cover off a lot of topics and items in a very small amount of detail, and you're of course welcome to approach WDV if you would like to discuss some of these areas in a lot more detail. So today we're going to hear about discrimination and violence experienced by women with disabilities. We're going to talk about stereotypes and negative attitudes about women with a disability and the sexual and reproductive health, and a little bit about how to make programs and services more inclusive and approachable for women with disabilities. And it's, I guess, address some of the specific sexual and reproductive health needs of women with disabilities in your service. So as we move on to the next slide, which is just really a heading indicating that the session which we're going to talk about, and so slide 5 and then slide 6, we'll talk a bit about what disability is, because there's no one definition of disability. It's a very broad term. The different definitions might stop people from identifying themselves as having a disability. And disability isn't just physical or visible. That's probably important to take away from this. So as we move to slide 7, continuing on with disability, WDV works under a model where people self-identify as living with disability. And that might be physical, sensory, such as myself, intellectual, cognitive, acquired brain injury, autism spectrum, chronic illness, and or mental health. So the UN Convention on the Rights of People with Disabilities talks about disability, including people who have long-term physical, mental, intellectual, or sensory impairments. And disability is an evolving concept and results from the interaction between persons, between people with impairments, and the attitudinal and environmental barriers that hinder their full and effective participation in society on an equal basis with others. That's quite important because it talks about the interaction of impairment and the environment in which people live. And it highlights that disability involves a long-term impairment. It also says that disability is more than the impairment. It's about impairment plus environmental and attitudinal space that holds people. All right, so moving on to slide 8. We're going to talk about a couple of models that have been influential in our understanding of disability throughout society. You might be familiar with some of this, the medical model and the social model of disability. And they're quite different in what they say and how they, I guess, help us to conceptualise disability. So in the medical model, disability is a tragedy. And it's something to be overcome or fixed. And we hear about it in the media a lot as someone so-and-so has overcome their disability somehow. By contrast, the social model, disability is a natural part of human diversity. It's just how it is, that there will be people, a certain proportion of people who have a disability, they've been created that way, and that's just part of who we are, society, creation, however you perceive it. So in the medical model, the problem is the individual's impairment, their body, and the way that they are. And so there's a lot of attention, if the medical model is followed, to either curing the person of the disability or fixing them, getting them to a point where they can sort of manage as normally, quote unquote, as they can, without the impairment being too much of a problem for them individually. So lots of normalisation, people being expected to be as normal as they could be and striving for normality, whatever that might mean. By contrast, again, the social model, the environments and attitudes are what cause the problem for people with disabilities, because impairments as such, also they might create issues for people, but they become amplified as soon as people encounter our society with its environments and attitudes which emphasise a particular way of being which doesn't include disability. And that's where the work needs to be done. As we come to solutions, so under the medical model, of course, the solution is to fix or cure the impairment, to make the individual more normal, as I said. Under the social model, the role of the solution is to make society more accessible and inclusive to everyone, and to remove stigma and discrimination for everyone. And if we think about the medical model again and service delivery, this is where it becomes important around sexual and reproductive health and other things. Services are delivered in separate institutions away from everything else that goes on in the world. And in the social model, the focus is on delivery within the community and mainstream services. That doesn't mean that sometimes individual services aren't needed and necessary, but the focus is on being part of the mainstream, and disability being part of the mainstream. In the medical model, professionals are the experts in people's lives, and they know best what a person with a disability needs and requires. In the social model, professionals are part of a collaborative team. So professional expertise is still valued. There's no threat to that, but people with disabilities are also valued because they have expertise in living with the disability that they live with. In the medical model, of course, the individual is sick, passive, and dependent on services and professionals who are fixing them. In the social model, a person is an expert in their own experience and self-advocate as much as they can. So if we move on to the next slide, and I'm happy for people to leave questions in the chat or in the Q&A, and perhaps, Joanna, if you see any questions that, that you think are coming up, that you see, happy to sort of take them. I'm aware that there's not a great deal of time, so we'll see how we go. If we move to slide 9, which talks about the human rights model. This is important because it's an extension of the social model, and it arose from the UN Convention on the Rights of People with Disabilities that I highlighted before. So there was a sense that the social model is, useful and, brought about a great change in people's thinking and concepts, but it was just lacking in a few areas. So the human rights model is different from the social model. It extends it in 4 ways. It embraces impairment, so it sees impairment as part of the human experience, which happens temporarily or episodically for some people, or permanently. And the experience of impairment is valid for people. It recognises that people with disability as having expertise in all matters that affect their lives. And equality doesn't mean treating everyone the same. It means that environments, institutions, societies need to be inclusive in order that everyone can be part of them. And lastly, and perhaps most importantly, it places accountability on governments to take action to address barriers. And there's quite an onus in the legislation on that in Australia. In fact, is required to report on its performance under the UN Convention on the Rights of People with Disabilities. So some people talk about disability pride, and it's a protest against medical model, really, which tells people to be ashamed of having disability. It's the converse. So disability can be an identity, and it's an integral part of who people are, something that influences everything about your life. And the concept is borrowed from queer pride. So some people, really identify strongly with that, about loving oneself, one's body as it is. And that can be immensely empowering as a concept. Self-identifying as disabled allows connection to a community as well of other people with disabilities who are trying to create changes in society. If we move on to the next slide, this brings in another concept that's going to be important, intersectionality, power and privilege. So intersectionality, we're probably quite familiar with this, I think. It's where 2 or more identities or experiences meet. And the interconnected nature of social categories such as race, gender, class, ability as they apply to a given individual or group. And it creates overlapping and independent systems of discrimination and different experiences of the world based on the identities that you have. And most people have more than one identity or category of intersectionality. And to be intersectional is to see and value the expertise and diversity of experience of everyone. And it remains responding to multiple forms of oppression. So it argues that we can't end, say, gendered violence if we don't also consider the impact of racism, the impact of capitalism and poverty. And disability is one of these identities as well. And it exists inside each group of other identities. So disability and gender, disability and race and culture. And it's unfortunately frequently forgotten in discussions around intersectionality. One of our roles at WDV is to try and bring that to the forefront of discussions. If we move on to slide 11, there are just some statistics that would be perhaps helpful to think about. So nearly 1 in 5 Victorian women and girls have a disability. There are references on the last slide about these too. So the second thing to be aware of, nearly 1 in 3 Aboriginal and Torres Strait Islander people report living with a disability. So that's quite a proportion of that population. In Australia, 45% of people with disabilities live in poverty or near poverty, and it's actually worsening. And a lot of that has to do with employment, or rather unemployment, or lack of underemployment, lack of progression in employment. The rate of disability for Victoria's culturally and linguistically diverse population is estimated to be around 22%, and it's slightly higher than the average for the general population. Women with disabilities from culturally and linguistically diverse backgrounds are less likely to report acts of violence or to access disability services. That's another consideration that will inform the discussion that we're later going to have. And women with disability, 44.4%, are less likely to be employed than men with a disability, 51.3%. So both figures are quite low compared to the national average, but for women, it's slightly lower in terms of employment. And that's useful to think about in terms of people's access to income and autonomy and purpose. High rates of disability and long-term illness in the LGBTI community, 23% versus 15% in general population. So again, slightly higher rates. Trans men and women reported even higher rates of disability, 38% and 34% than the wider LGBTI community. And LGBTI people with disability are significantly more likely to be unemployed, 20%, versus 4% having experienced discrimination, harassment and abuse. So we're seeing higher rates depending on the identities that that people have. If we move on to the next slide, we're going to talk about the concept of ableism. We talk quite a lot about sexism and racism, lesser extent about classism. Ableism is another one that is helpful to think about. And the terminology that I've used there on the slide is left on the outside. That's the impact that it has. And so ableism is discrimination and social prejudice against people with a disability or who are perceived to have disabilities. And it defines people by disabilities that they have and assumes certain things about them, such as inferiority to everyone else, the great normal, people without disabilities. And it's more than just individual views, because people might, the population might say, I like people with disabilities. I think they're wonderful and amazing and inspirational. In fact, that's ableism, because it's not just about what individuals think. It's a systemic form of oppression that privileges what is perceived as normal as opposed to what is seen as different and disabled. And it's reinforced by systems, attitudes in society, by the way that society operates. And stereotypes like sexism and racism, similarly, are used to justify discriminatory behaviour and attitudes. And it's not just about some examples that might be useful to think about. Systemic violence, disability as a last thought. So inaccessible violence response services that people can't use. Inaccessible design of environments. Transport, which can't be used by everyone. The emphasis on active transport obviously has a lot of benefits for environments and the health of some people, but of course isn't available often for people with disabilities, and for some people might present a safety barrier. If we move to the next slide, we're going to move into the area now of sexual and reproductive health, because that one, then we'll link it to disability and ableism and the concepts that we've talked about just before. So I think we all are familiar with sexual and reproductive health being at this event. Sexual health, this is a quote, sexual health is a state of physical, mental and social well-being in relation to sexuality, and it requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination and violence. It's from the World Health Organization saying that. So the following slide, 14, if we think about the sexual and reproductive healthcare rights of women with disabilities, again, coming back to the Convention on the Rights of Persons with Disabilities, it's an important piece of legislation, a landmark piece of legislation, in fact, when it was passed by the UN. And a lot of activism is derived from its provisions. And so where it talks about areas linked to sexual and reproductive health, access to information and services, living free from violence and coercion, privacy, spaces and personal information, eliminate discrimination against persons with disabilities in all matters relating to marriage, family, parenthood and relationships, including in the areas of family planning, fertility and family life, and equal access to sexual and reproductive health programs in the community. That's what so all of these provisions exist within the legislation, and on which Australia has to report to the UN, and on which the disability sector produces shadow reports about how we think Australia is doing in those areas. So these have been specifically highlighted by the UN because these rights are so often breached for women with disabilities. And a rights-based approach is what should underpin all of the work across the violence and reproductive health sector. So reproductive justice is another term that might be helpful in our conceptualisation of this, dismantling systemic opposition that reinforces marginalisation, inequality and violence. If we move to the next slide, we'll talk about a few concepts which relate to the experiences of women with disabilities to sexual and reproductive health. So the first concept is reproductive coercion. You might be familiar with that term, and violence with disabilities. Reproductive coercion is using power and control to limit women's choices in relation to reproduction, contraception and abortion. So women with disabilities experience the same kinds of reproductive coercion from intimate partners and other people as do non-disabled women. So all those coercive elements are still there. And disability has a few others as well. Women with disabilities, the additional experiences of ableism, which we talked about, attitudes which stereotype people, discrimination, and violence. So perpetrators use disability against women with disabilities to silence and control their decision. So violence is more intense, occurs over a longer period of time and often with more perpetrators. So abuse of women with disabilities is intersectional, as we've said, and it means that sexism and ableism combine. And it means that sexism and ableism combine. So abuse of women with disabilities is intersectional, as we've said, and it means that sexism and ableism combine. So abuse of women with disabilities is intersectional, as we've said, and it means that sexism and ableism combine. and that creates disadvantage and inequality regarding reproduction in all its forms. So taking a wheel off a wheelchair, taking a wheelchair off a woman, removing household items from their places so that a woman with low vision is disadvantaged, or create gaslighting. So moving on to slide 16, where we'll continue to talk about reproductive coercion and another concept which is sadly part of the history of disability, eugenics. Historically, sterilisation was driven by eugenic ideas of fitness, and these are still held widely in society today. So it was thought to sterilise or remove children from anyone with undesirable traits. So people with certain disabilities are encouraged not to have children. And if they did have children, there were ways found to remove those children from the parents' care. And it was aimed to prevent disabled children from being born, which is very clear that this, in fact, the history of contraception, obviously there have been benefits from contraception, very closely tied with eugenics. In fact, it was given to people in the earlier 20th century who were thought to be likely to produce children who are unfit, including children with disabilities. It's worth keeping that in mind. So today these ideas are seen in stereotypes, of course, and negativity around sexual activity, disability, and women. So stereotypes include, assuming people with disabilities can't have sexual intercourse, relationships, or don't want to have sexual intercourse or relationships, and that they're undesirable. Even if they do, they're undesirable anyway. And assuming women with disabilities can't care for a child. There's much less scrutiny, of course, on the parenting of men with disabilities. I'm not sure why that would be, but let's think about that one. And so disability is perceived as a burden, and disabled people don't contribute to society. Therefore, they have no value in terms of participation in relationships, especially relationships which are based on equality and respect. However, there are some other stereotypes operating with women with disabilities because, well, there are two. Women with disabilities are seen as, in fact, hypersexual, not being able to control themselves in any way, or they might be seen as completely asexual, not at all interested. The reality is, of course, that, like everyone else, there's this whole spectrum of behaviour around sexuality, which women with disabilities could fall into any of those categories or most likely in between. And while people might not say that they have these attitudes or what they're doing is to continue on with eugenics, it still heavily influences people's ideas about disability, and it creates what is called unconscious bias around sexual and reproductive health for women with disabilities. And for reproductive coercion for women can also look like enforced or coerced abortion, or forced or coerced sterilisation, excessive use of long-acting reversible contraception without consent, and disregard for consent and decision-making for women. And this is perpetuated by systems such as medical practices and individuals such as health workers, unfortunately. If we move on to slide 17, which talks more about forced or coerced sterilisation, and of course we're not saying that women with disabilities can't consent to sterilising, being sterilised themselves, because they may wish for that to happen. The problem is that that decision is taken out of their hands and made for them in a lot of cases. So sterilisation without informed consent, and it's against the human rights legislation, of course, in Australia. It's restricted, but it's not illegal in Australia to do that. It's a form of violence and control over a woman and her autonomy and right to make a decision. And it's often targeted at women with intellectual disabilities because of perceptions that they can't make decisions, or it's a misguided attempt to manage menstruation and to prevent pregnancy in cases of sexual violence. Historically, it was hidden from women with disabilities. So there were women, in previous times who had been sterilised and didn't know they'd been sterilised, especially if they lived in institutions and things. Today, women are often taken overseas by family members, or they might find a specialist who will hide the true nature of or reason for the surgery. And it still happens. There was a Senate report where this was talked about in 2013. So it hasn't gone away. And it's often a complete hysterectomy for a woman for, a fairly straightforward procedure. So removal of the uterus, not the less invasive kind of sterilisation of blocking the fallopian tubes. Of course, it's very difficult to gather data on this because it's not something that people want to be revealed. And so the information that WDV uses when we advocate around this is from a Senate inquiry into involuntary or coerced sterilisation of people with disabilities in Australia, which happened. So there are submissions there publicly available for you to read. Okay, so moving on to the next slide, and there is quite a lot of information here. Forced or coerced abortion is another issue that is encountered by women with disabilities. There's a quote from an activist, which I'll read. As a disabled woman to the outside world, my choice to end a pregnancy was seen unquestionably as the right decision. This view potentially stems from fears around passing on genetic disorders. It's a fear that has its origins deeply rooted in eugenics and what is subjectively deemed as whether or not a disabled person can live a good life. Or it can come from the unwittingly negative views that surround bodies and ability to adapt or cope with motherhood. Nicole Lee is the author of that quote in 2020. So women with disabilities have similar experiences, of course, around coercion from outside, about fertility, about abortion, but motivated by prejudice in the form of ableism. So women with disabilities have the additional excessive scrutiny of parenting ability that other women have, or to a lesser degree have. Parents, families, carers worry about the impact a child will have on the woman. And that's seen as a rationale for sterilisation. They also worry about the impact of having a woman with disability as a parent of a child. And I guess the issue is that it prioritises the desires and opinions of non-disabled people above rights and views and autonomy of the woman herself. And that is the issue in question. If we move to the next slide, where we talk about contraception as a part of coercion, and of course we're not saying contraception is bad, but we are saying that long-acting reversible contraceptives stay in the body, as we know, for an extended period of time, between 3 months and 10 years, I believe. And the misuse of these in women with disability is where the problem is. And it's more likely to be used in women with intellectual disabilities, and it's excessive use of Implanon, Depo-Provera through injection can, again, limit a woman's capacity to make decisions about this herself. Women, there's lack of informed consent, and there's no discussion of the impacts on menstruation, fertility, how it works, or how long it lasts. And it's assumed that women don't have the capacity to make these decisions if they're given the right information presented in accessible and inclusive ways. And contraception, unfortunately, is used as a protection against the consequences of sexual violence. So it's seen that sexual violence is going to occur anyway, so we may as well ensure that there's no pregnancy as a result of that. That's seeming a benevolent view. We don't want that consequence. It would be more helpful, of course, if sexual violence was eliminated, and so women wouldn't have to undergo that anyway. If we come to the next slide, slide 20, consent and decision making. guess this is the concept that, that we're talking about and advocating for in this space. So at WDV, we talk about supported and informed decision-making, respectful of bodily autonomy and dignity of risk. Recognising that the decisions some people make aren't the decisions that we ourselves would make or would like them to make. I think that's a dilemma in this area anyway, whether a person has a disability or not. So the individual and not the family or carers are the ones who can and need to be supported to make decisions in the best way that they can. And that does mean sometimes adapting information to make sure it's understood, and putting quite a lot of work and effort and conversation and discussion with women so that they are truly involved in and autonomous in making decisions. So assumption of competency to consent as the default, rather than assumption of incompetence to consent as the default. So giving information and time, professionals actively addressing power imbalances, working collaboratively. Informed consent using communication methods, of course, that women with disabilities prefer and can access. Continuous consent during processes, assumption of competency, that women have the competency to consent all the way through, and that women themselves should be the givers of that consent, and that they have a right to make decisions for themselves. And women can make informed decisions if they're given information and time and appropriate processes. And women are treated or need to be treated as experts in their experiences, professionals actively addressing power imbalances and collaborating with women to provide support, information, opportunities for women with disabilities to make decisions. So let's talk about how we do that in practice, because that's where I would imagine lots of questions will arise. If we move on to the slide 21, and we're starting to now think about how we make SRH practice accessible for women, so that they will use the services and make decisions that are going to be best for them. So slide 22 is where we get into, I guess, the practicalities of how to ask about disability and access needs as a question that a lot of providers have. So just think about, what you currently do in your practice about disability and accessibility, and what ideas and thoughts are stopping you from asking the question. How can we continue working from a rights-based perspective when it comes to disability? So in terms of how this is practically achieved, asking if people have a disability or access needs ensures that services are inclusive in their practice and breaks down stigma. It doesn't annoy or upset people to be asked if they have a disability. They can say no if they don't have one. But if they are asked about access needs, it clearly sends the message that the service is interested and wanting to be accessible. And it's much easier then to have those needs addressed. So ableism, as we have said, drives the fear of asking the question because of what might come out, that people might actually have needs, or people might feel a bit uncertain as to how to meet those needs. And it can be helpful to say why a service is asking about disability so that people aren't inadvertently put off about information being collected about them. And so I guess the thinking around this is that everyone is different who comes to the service, and what we can do, how can we meet your particular needs? Again, this is taking a rights-based perspective. Every disability and each group of people has different access needs. And you won't know all of them because disability is diverse, but by asking questions, collecting some data, doing some research, services will slowly come to a greater sense of skill and knowledge in this area. So, there is a fear of making a mess of it, asking the wrong thing the wrong way. Learning, it's a process of learning. And asking to be educated if a mistake is made, expressing repentance for that mistake, and asking to learn from that person. If we move to the next slide, 23, another question that might be asked is how does your organisation encourage contributions from women with a disability? So if you think about the practice in your organisation, what you might currently ask or say to women about contributions that they can make, what are some ways to engage with a woman with a disability who's had limited access to information and services so that she can feel part of the service, feel that her experience is valued, and it will influence the way that she receives services in a positive way. So it's important as a starting point to speak directly to women with disabilities themselves, not to their families or carers or whoever happens to be there. And it is helpful for us, for service providers, to acknowledge the discomfort of challenging someone. So we may need to simplify the language that we use in service provision and to check that it's being understood, checking more than verbal responses, because someone might say that they understand, but they might actually not be. So checking body language if you can, or perhaps phrasing information in different ways, clarifying that concepts have been understood. Using simple language doesn't mean talking down to someone, it just means being clear. I think a lot of service users would value that anyway. Speaking to them as an adult, but using simple language rather than as a child. There are reasons why women might not be able to use standard communication based on disability. There are then services such as the relay service for women who are deaf and hearing impaired or have other communication needs. It's important to speak to directly due to the sensitive nature of the topic, SRH. So really bypassing someone to speak to someone else because they can understand the woman isn't going to create the best outcomes for the woman herself. And people have years of understanding of living with a disability because they've done it. So as a professional, it can be helpful to acknowledge that in our minds and with women with whom we're working. So neurodiversity and consent, of course, information needing to be accessible and for that to be checked with women to make sure it is working from a rights-based perspective. Using there's a script for pregnancy options counselling, I believe, that certain services 1-800 options use. And there are some other useful resources that have been developed by organisations who have expertise in this area, which they'd be happy to share. I guess another concept to think about is that women with disabilities have the same needs as women without disabilities. So making choices about their bodies, being mindful of ableist attitudes that preclude women from using the service or contributing. Moving to the next slide, and thinking this time about how best to ask about additional needs in relation specifically to sexual and reproductive health without sounding patronising or in any way denigrating to the woman. So thinking about what respectful language sounds like when it's used. If we move on to the next slide, because this is where some organisations can struggle a little bit to find or to make communications and resources more accessible for women. If we think about our organisations, what content and resources currently exist that are accessible or could be made more so? What does an accessible service mean to you as a team, as an individual within the team, as an organisation? So a good concept to think about here is integrating accessibility from the beginning as part of the core business of the organisation, rather than thinking about it at the end when someone makes a complaint or they call and they're needing a service and it hasn't been considered previously. So thinking about and implementing systems to use services such as the National Relay Service or Auslan interpreters, other communication such as accessible websites and information in accessible formats from the beginning, and that includes budgeting for all of those needs. Often the barrier that is cited is that it's too costly. And so funders, in fact, need to receive the message very clearly that this type of accessibility needs to be budgeted for in specific line items, as we do at WDV. So thinking about, the audience who are using the service, easy English, plain English, training for staff, asking people if they would like material in plain English, simple English, using image descriptions of alt text. So for people who are vision impaired, such as myself, graphics, might look great, and there's obviously a need for them in organisational brochures, but if they're not described, then they have no meaning for anyone with a vision impairment. And that goes for social media posts as well, using Word documents rather than PDF for information, because again, that creates barriers for the use of screen readers. So I'm actually reading these slides using a Word document to which I've converted them because it's in Braille, because that's my preferred means of communication, rather than listening to the screen reader read the slide to me and then somehow delivering it to you. That would be a really awful presentation for you to listen to. Moving to the slide 26, just recapping really what we've covered today. And I realise again that it's a lot, and we've talked about a lot of things: disability, gender, ableism. We've talked about models of disability, sexual and reproductive health care, and the rights of women with disabilities to these, power and decision making, SRH health topics like sterilisation, contraception and abortion, inclusive approaches to service delivery such as language, thinking about trauma-informed practice, because that's what this is, assuming that there has been violence and abuse because of its prevalence. There is a little bit of time, if we would like this, for questions and answers. You may have heard quite enough of me for a while. So if you have questions or if any have emerged in the Q&A, I'd be very happy to take a couple quickly.
Hi, Helen, it's Ashley speaking. Thank you so much for that presentation. It's a great reminder for us all to reflect on and challenge our own preconceptions and ideas, around ableism and disability, and really challenge our own personal practice. So thank you for that. There is a question in the chat, and it relates to a comment that someone has made where they've experienced workers, support workers, bringing in people with disabilities and encouraging them to have a termination of pregnancy.
Yeah.
So the question that someone has asked is, when you're providing clinical services to a person with a disability, how do you ensure that you're acknowledging the person's autonomy when they do have that support person or carer there with them?
Yeah, I think the first thing to do would be to somehow make sure, create a space where the consultation is between the clinician and the woman. There are very, very few reasons why a support person and carer needs to be in the appointment themselves. They might have provided transport, they might have filled in some forms. There are, unless the situation is so dire that someone needs a carer to operate their communication device and, support their breathing or something, really, there are very few instances where that person needs to be there, and it might need some preparation beforehand, before the person actually arrives, as to what their support needs are, so that the clinician can provide them rather than relying on the support worker. It's a little bit like the situation used to occur, and probably sadly still does, when there were women from culturally and linguistically diverse backgrounds who'd come into a setting, and their child would be there as the interpreter. We know that that's terrible practice on a lot of levels. In the same way, using a support worker as the communication assistant, unless it's absolutely essential for that to happen, isn't going to produce the best outcomes for the woman herself in her decision making about the termination. She may want the termination, she may not, she may be unsure and need that, counselling and support. Has that provided enough of a response to that question?
Yeah, thank you, Helen. Someone else has asked for your reflections on finding the balance of incorporating accessibility into practice. So I guess they're asking the line between providing too much information to give people informed choices, balancing
Yes.
that, presenting too much information and then confusing the situation and making it harder for someone to make a decision.
Yeah.
So do you have some reflection upon that, Helen?
Yes. I guess the reflection is going at the pace of the individual to whom the information is being provided. So checking in with them about what information they might need, the format in which it's delivered, the amount of information. I mean, as people, we're bombarded by health information all the time, and its credibility may be questionable in some instances. You know, a lot of people consult Google as their first primary health appointment. So checking in with women about, you know, what information they need and asking if they have questions, because that will help you to clarify any gaps in the information that they have.
Thanks, Helen. There's lots of comments in the chat just thanking you and saying it was an amazing presentation, so much information. I agree, lots of things for us to reflect on. Were there any other questions that people wanted to put into the Q&A or to ask through the chat? No, that's okay, just lots of thank yous, Helen.
Thank you. Thank you again for the opportunity. I'm aware that I've covered a lot in a very short time.
Sorry, I'm just going to jump in again. There's a question that someone's just put up where we could find the easy English script for pregnancy options.
Yes, I believe 1-800 My Options has done some work in that area. They did some training with us about a year ago or a bit less. And they do a little bit of work in that space. And so I'm sure they'd be interested in supporting anyone else in that practice.
Yeah, great. I might even have a little bit of a look during the break and see if there's a link.
Yes,
we can put
it may be something that's in-house, I think, rather than on their website.
Right. Well, we will seek that out.
Yeah. Great. And if anyone has any questions or any other supports you might need from Women with Disabilities Victoria, you're welcome to contact us going onto our website and making contact that way through email or social media. And depending on the nature of your question or inquiry, it will either be forwarded to me or another manager.
Wonderful. Thank you so much.
You're very welcome. Enjoy the rest of the day, everyone.
Bye, Helen.
Thank you.
Just a reminder that this day is being recorded. So people did want to refer back to some of the content or maybe share it with their colleagues. Please feel free to do so. Had some excellent content so far, and it's great that we've been able to capture that. We do have another break now. There's quite a few breaks that have been woven into the day, and I know sometimes in an online format it can be distracting. You hear your little email dings coming up, and you're getting phone calls and things, but having those breaks incorporated, that gives you the time to respond to all of that. So I hope that you can use it in that capacity so that when people are presenting, you can be really present and engaged in the content that's being delivered. So we'll go to a break now, and then we will be returning here at 11:30. Thanks, everyone. Hi. I would now like to introduce from VACCHO, the Victorian Aboriginal Community Controlled Health Organisation. We have with us Anne Roseman, Georgie Taylor and Kylie Moreton, who are having a conversation with us based on the presentation topic, All the Mistakes I've Made, Lessons from the Field. Thanks, Anne.
Thank you so much, Ashley. So I'm Anne Roseman, and my talk is All the Mistakes I've Made. The others aren't going to do that, but that's my talk. So I'm going to do a little bit of a chat today. But before I do, I want to acknowledge that we meet today across many Aboriginal and Torres Strait Islander lands. I'm on Wurundjeri land here in the Kulin Nations, and I'm zooming from Boleke Beke, which is, I don't know the pronunciation, but the word for Brunswick, in Naarm, in Melbourne. I'm so grateful for all the rich rivers, oceans, mighty deserts and animals and plants of the majestic lands that have been looked after by Aboriginal and Torres Strait Islander people all for thousands of years. And I'm really amazed at the beauty of our nations in Australia, here in Naarm as well. So I'd like to pay my respects to elders, past, present and emerging, and to all Aboriginal and Torres Strait Islander people who are zooming in with us today. I also want to pay my respects to every single person that's attending this room. You are my people. Sexy health is my work, and I love it. So I'm really glad that you're here to share with me today. So I'm going to tell you today, I could have done a big PowerPoint and said, oh, VACCHO, but I'm just going to tell you, I've been thinking about this presentation for a while. So I work for VACCHO. We're the peak body for Aboriginal health, and I'm so lucky to be working in Aboriginal health. My name is Anne, and my grandmother was a whore. She married a monks. Today's yarn is all about the mistakes I've made working in Aboriginal health. As a white woman, my grandmother being a whore, and she married them monks. And we're going to talk about all those experiences that I've had. And I think that's sort of ironic in that my grandmother's name was whore, and I work in sexual health, don't you think? And that she married a monk. I think that's a funny thing. But this is one of my mistakes. So I'm going to talk a bit about how I made that mistake. Welcome to my bloopers, reflections of a white woman and the many mistakes I made. So mistake number one, when I worked at Disabilities Victoria, that was my first job working with a portfolio in Aboriginal health, right? So I went to the community health promotion events called Sisters Day Out, and I loved them. They were just great health promotion events. And I was really excited to be there, and I'd hand out these Hepatitis Victoria lollipops and give it to people and say, hi, my name's Anne, and my grandmother was a whore. Really, I did that. And I thought, you can see how I've made mistakes. Like, it was my clunky way of trying to make a joke about myself, my mob, and about being a little bit about being a white woman. You see, I knew that this was a normal way that when meeting someone in an Aboriginal community to ask, who's your mob? So I thought, I'll get it out there. I'll say I'm an Irish whore. And I thought it was a bit funny, but actually it was a little bit too full on. So underlying, and I was trying to reflect on, why would I do that? And partly I was a little bit nervous. And underlying my introduction was some discomfort in myself. And I reflected on that, and some fear of maybe doing the wrong thing. And my fear, I was thinking where it came from. Please interrupt me and ask me a question if you need to, because I don't mind being interrupted. It seems weird, my monologue. But my fear came from being a recovering Catholic, and some discomfort, I suppose, in not wanting to be perfect and not wanting to make a mistake. But on closer inspection, I think me being part of White Australia, I think there's a deep fear of Aboriginal and Torres Strait Islander people that I experienced. I feel like I have some unfinished business, probably some lingering white guilt of the horrors of the past genocide and the way that intergenerational trauma is ongoing, and the lived experience of so many people of trauma today. Colonisation had a massive and ongoing impact, especially in Victoria, where most people experienced smashing of their culture, and their language and their law. Many people are still seeking their mob in Victoria. So me asking that, people often, one of the things I love about working in Aboriginal health is people actually don't really care how much money you have, what you wear, or how old you are. They want to know about you, about your family, your values. Are you trustworthy? And I love that. I really love it. So why I'm going to tell you this deeply personal story. It's a personal yarn about me and my story. It can also be traumatizing talking about my family. My cultural safety journey is ongoing, and at every town and new town, I try to do a cultural tour. I did one when I went to Sydney. I spoke about my reflections. I found out my mum's family were very silent. The Hall family were really worried about, we didn't know much about them, but I found out that I was related to John Hall, who was an infamous convict who came here with Elizabeth Love in 1791 on the Second Fleet in Matilda. So I was telling this story to this woman who was giving me a cultural tour of Sydney, showing me the middens that were embedded in the early colony buildings with the shells from the middens. They didn't understand the system of middens that were there. And I was learning that Aboriginal people would actually put the last piece on the midden was something you would not take from the ocean because you wanted to make sure that you didn't overfish the ocean, that it was seasonal, that there was a system. The whitefellers came, smashed up the rock, and then put it into the buildings. And she showed me that spot. But I realised that talking about my mob and talking about my family actually brought pain to her. She turned to me and said she did not know her family, as her grandmother was stolen. I felt gutted, and I saw her pain, and it reminded me of this. I had reminded her of this again. Another conversation I had with my colleague, I mentioned my whole family had known human hovel, and they'd followed them to claim land around Albury and had stolen Aboriginal land. Again, it was my clunky attempt to acknowledge my family's part in colonisation and probably own my own white guilt. Again, I was not mindful of how I brought this up. I don't need to remind people of ongoing trauma that they live every day. Rather than making it a big deal, for me, it was important for me to reflect on this mistake. It's my job to do this, not my Aboriginal colleagues. And that's the big story I want to share with you. It's my story. We all need to deal, as white people I'm talking to, we need to deal with this white fragility in many ways. Paradoxically, we often turn to the Aboriginal people to do some of this work for us, to meet our KPIs. We need to work with Aboriginal people. You will meet my KPI. To ask the only Aboriginal person you know or your organisation to do your RAP, to ask them to do the history telling, and for reassurance that we are doing the right thing. This can then add to their own workload and often Aboriginal people are doing a lot of work in their personal and their private space, and they have a lot of cultural responsibilities. They also may not be confident in this area. Sexual health may not be an area they're confident in, and they may not understand local protocols and responsibilities. So I think some of this explains why white Australians have their own issues. We can be very uncomfortable, especially for white middle-class professionals. We don't want to look stupid or unprofessional. I don't. It's this mixed cocktail of guilt and stupidity and fear that what I'm going to share candidly with you today. I see this not only in myself, but mirrored in the people I work with, organisations and systems. I constantly need to check in with my internal racism, both outwardly, explicit, and internal, implicit, and make it real and see it. We often work in the shallow end because we don't actually address that in ourselves. I invite you to work in the deep end. So just a bit about myself. I grew up in a wealthy middle-class neighbourhood in leafy eastern Melbourne. Most of my childhood, I never knew or met any Aboriginal people. My mother, bless her, read me Dreamtime stories in the 1960s. This was pretty progressive, but she also told me that unlike many other places, Aboriginal people were passive and did not resist colonisation. That's mistake number one. I believed her. This was reinforced by the history lessons of Captain Cook and all the rest. Nothing was said about the real history, about the frontier wars and resistance. Why I share this with you is that it still affects me today. The messages of Aboriginal people were often negative, lazy, unreliable, and that they drank too much. When I was at university, I was trying to visit a friend who lived in inner city, Sydney. I happened to find myself lost in Redfern. I felt really unsafe. A fella called out to me and said, "Hey, you, where are you going? Who are you looking for?" My first response to him was fear, and I blocked him out. I just didn't listen. I can't remember what I said, but I probably nodded thanks. But the key thing here is I didn't listen to him. As a result, I continued to get lost. And I encountered this man again because I went around in a circle. He patiently gave me directions and I found my way. This was one of my biggest learnings. I need to listen more. Later, I encountered an Aboriginal religious organisation, as I'm a recovering Catholic now, and they invited me to a painting session. I thought they were doing Aboriginal art. It was actually, we were helping them to paint their house. It was a hot day and here I was working hard with a paintbrush and others were standing around talking and drinking. And I thought, was someone going to get drunk? Was I going to do all the work? Again, this was my internalized racism, lazy, drunk. Many years later, I joined ANTA and started to educate myself. I learned later in my studies of the wars and of assimilation and of genocide. So some of the lessons I've learned is to stay in my lane. Luckily, I haven't made this mistake too many times. As mistakes do, they come from a good place. I'm intrigued by Aboriginal ways of knowing, being and doing. Aboriginal Australia is completely diverse. Working in a Black organisation, it's often assumed that you know a whole lot, and it's also assumed that you are Aboriginal and Torres Strait Islander. It's really important to make it clear that you are not an ally, that you are not Aboriginal from the outset, that you are not mob as soon as you can. If I wear identified clothing, I make it clear that I'm an ally as soon as I can. This can be a great opportunity to have a conversation about our Aboriginal sovereignty. It's important also not to mistake informal settings. Some part of this reason I love working in Aboriginal communities is the humour, goodwill and informality. Of many mistakes that I've made, people are very forgiving of me. But this, and people are quite informal in the way people interact. I love that. But this informality does not mean there is no structure. I've been very blind to some of the formal protocols that exist within communities. They are very structured. And this is a complex area. It's not simple. Working with elders is not a simple exercise. Sometimes I've had requests in sexual health, oh, can you just get an elder to do a video? We're doing it in 2 weeks. This is not something that just can be snapped into action. You need to be led by local knowledge and form your own relationships and expertise. Relationships are everything. So, you know, people have to put in the skin in the game into making those relationships. And I know it's hard. I worked in a mainstream organisation and it's really hard to develop those relationships. But if you persist, my experience is you will be, and you have humility with that, you will find those relationships. One day I sat for hours in a service wanting to speak to one of the managers. They got very uncomfortable because I just sat in the waiting room. Finally, I did meet someone from that service and I started to meet with them. I didn't understand that Aboriginal services are so busy and that I'm not their top #1 priority. I lacked a bit of humility there. So I just sat in the waiting room. And that was and it was great because I got to see the comings and goings. I got to see how busy they were. And they did come to me. They'd made time for me, which was really nice as well. But cultivating relationships, they are everything. So listening and not asking too many questions is important. So listening involves listening to what is said and what is not said. Sometimes I talk too much. Here I am talking too much again. I constantly have to tell myself to stop and listen more. Deep listening is a key part of many Aboriginal and Torres Strait Islander communities. This means not asking too many questions all at once. It's sitting. I've been working with a vaccine van and I was working with this nurse who was very exuberant like me and a bit full on, and I loved her. And she really went the extra mile with people. And an elder came and I picked up this elder, and this elder was coming to get vaccinated. And this nurse was so enthusiastic, wanting to ask this elder a lot of questions. The man turned around to her and jokingly said, "Oh, when are you going to take me to the station to take my statement?" He was trying to do it in a really kind way to say, "You're asking me too many questions. You don't know me." The nurse sort of realised something was wrong. So then she said, "Oh, maybe he needs to go outside." So she took him outside, but she went straight up to him and stood close to him. She thought she was reassuring him by taking him outside and then keeping on talking to him. And later when I took him home, he said, "White people think if you ask lots of questions, it'll make you feel more comfortable." He said, "We don't. We like a bit of silence. We're shy." I said, "I'd have a chat to them and tell them what he told me." He was very gracious in his reply. He said, "Don't worry, it'll be all right. They didn't mean anything wrong." But I think that's the thing. I've been guilty of that mistake as well. I ask too many questions. I'm too enthusiastic. I'm too full on. I say my grandmother was a whore or something like that to someone I don't know. People don't know you. It's going to take a while for people to know you. So the main thing is you've got to just let people do it at their own pace, watch and listen. So when taking a sexual health history, it's really, the other thing is when you're asking people a lot of questions, people are very suspicious of that. They're very suspicious of you, and rightly so. I'm suspicious of myself sometimes, but we have to do things in a different way. We have to learn a different way. We often talk about health literacy. We need to improve health literacy with Aboriginal communities. That's completely wrong in my book. Health literacy, you're barking up the wrong tree. What you need to do is you need to spend time to understand how to pitch something to an Aboriginal person in a way that they can understand it. So that's a skill that you need to develop. You need sexual health literacy to understand how to present something to an Aboriginal community in a way that people understand it. I've worked in prisons, I've worked in schools, I've worked all over the place, and you have to actually be quite nimble in the way you pitch it, because another mistake I made was I did a youth camp with a fellow who'd worked up north, and I had been working and doing a pretty full-on work in prisons with fellas, and it was a really different environment. And then I worked with these other kids that a lot of them went to private schools, and the fellow was really, even though we broke up the girls into women's business and men's business, my language was just too full on, and I didn't adapt my language to the crowd. And it can be hard to work out where to pitch it, but that's your job to work it out. And humility then, when you've made that mistake, to not overburden people, but actually have the humility to reflect on what you've done and say, gee, I stuffed up there. And tell the person, I'm sorry, I made a mistake, I didn't get it. And not to do it again. And sometimes I've worked with people from all spectrums. Sometimes they're professors and they think that they know a lot, and they do know a lot of the content area. But in terms of engaging Aboriginal communities, they don't always know a lot, and they think they do. People don't tell them that. So sometimes I've had to say, you need to do more than just one session online. Your cultural safety journey is ongoing, as mine is. Even though I work at VACCHO, I don't know everything. I make mistakes all the time. So you need humility. This professor was like, oh, really? Aboriginal people need to know those words. I said, if you tell them those words, they will turn off. They won't tell you that, but they won't see you again. So you need humility to say, you don't know everything, no matter how big you are in your profession. And you need to have trauma-informed practice. As I've said in some of my other mistakes, quite well-meaning, I thought I was engaging with people, but actually was bringing up more trauma. So we need to tread lightly, very carefully. If in doubt, go slowly. It takes a really long time to do stuff. So if you think it's going to take you 2 months, double it or triple it, because you need to spend a lot of time. So that's what it takes, a heap of time to do that. So anyway, that's it for my presentation. Do we have any questions? It's a big monologue, that one.
And there was just a quick question when you were referring to saying, oh, Aboriginal people don't need to know those words, and someone just wanted to ask what words you mean.
Well, I think it was just the way she was saying it was really gung-ho. And I knew that community, and I knew, like, sometimes when people, you don't understand that sometimes people, because of the stolen generation, because of, like my grandmother Hall was actually a orphan, and she used to shower under a sheet because the nuns where she grew up said she wasn't allowed to look at her body. And actually a lot of what I found is a lot of Aboriginal women don't have basic knowledge about their body. They don't understand sometimes some of the plumbing even. So there's some things around bodies, basic knowledge you take for granted. And if you use big words, it might trigger women to just completely turn off and feel really, feel that they don't know anything. So it triggers a whole, using words. Some people really struggle with reading or writing or big words. It brings out a whole lot of fear and sometimes shame, which doesn't really belong to them. But and so sometimes you have to be really mindful of the language that you use and do some research before you present about how to pitch something. And it does take a while to learn that. It's not something that, like, I'm a really highly experienced health professional. I've worked in a whole range of areas, but it's like going to a new country as a white woman. And I love that because I learn something every day, but it's not that you don't use the words, but if that's your entry into the community and you use some of those words. When I went into prisons, I was going to talk to one of the prisoners about hepatitis and shame. And one woman I said to her, oh, how should I do that? She pulled me to the side and said, see that woman over there? You don't talk like that. She will just explode. So you do not know what you're coming into. So you have to tread lightly and cautiously because you don't know, unless you know your group very intimately, you don't know what you're coming into, especially with sexual health, because there's a stolen generation, there's lack of awareness. Well, there's not lack, but it's about body, like basic stuff that you might assume knowledge that women have. Women may not have. And if you present that in a language way that triggers people to think, oh, I don't know that word. You think I'm dumb or you think I'm that. And it triggers a whole spiral in somebody's mind sometimes. So there is a real skill and you don't need to patronize people, but you just need to think about how can you say that in the most essential way. And there is always a way to present information like that. And if you do, like, people pull me up, like I did a training session on syphilis and I used a word, I used congenital syphilis. And one brave woman said, what does that mean? And I went, oh, because I keep making those mistakes. Yeah.
Thanks, Anne.
And then I go, I'm sorry, I forgot to explain that. So if you do need to use a word, you need to explain it. The other thing that happened to me once, I was doing a training with a group of people, deadly sexy training, and someone just popped into the session and I went, who the hell are you? And this experienced doctor came into the session because she said, I want to do some work in Aboriginal communities. I said, oh, that's great. She goes, oh, can I do something? And I said, yeah. So I invited her to one of these sessions. What had happened is she'd invited her student into my session. She didn't tell me she was inviting her student because she's used to being powerful in her organisation and she could invite her student, but she didn't ask me first. So that student that came in could have undermined all the work that I was doing. I didn't know her cultural safety. I didn't know her background. And that was a huge risk. I actually allowed her to stay in. So the mistake I made there is not making it really clear to that health professional who was very highly experienced. No, you don't have the power. See, white privilege means I'm used to being powerful. I can do what I want. No, you can't. You can't do that. I won't work with that professional again because she texted me after it and she said, oh, and I hope it was all right. My student came. I texted her back and I said, actually, no, it wasn't. And she never replied to that text. And that was really telling. And the beautiful screen, we had this project and sometimes there was a fill-in person and she went up to the people and she was well-meaning and she said, oh, to one of the women that came along to the screening, she said, oh, you don't look Aboriginal. That comment almost wrecked our entire project. And that woman just hadn't done enough understanding. Or another time I worked in a helpline and when I said, why do we ask if someone's Aboriginal? Why do we ask if someone's Aboriginal?
And that relates really well to a question that we've got here, Anne. Building rapport in hospital settings and in clinical settings, needing to ask those questions of, do you identify as being Aboriginal or Torres Strait Islander? Is there any involvement with Department of Health and Human Services? Those standard questions, how do you build rapport when you're asking those? Because they can be met with discomfort and resistance sometimes.
So the person that asked that question, who's the discomfort? Who's it coming from? And maybe you could just answer that. And I put it out to you. For Aboriginal people, why do we ask that question? Put it in the chat. Put your responses in the chat. Why do we ask if someone's Aboriginal or Torres Strait Islander? Maybe someone could read them out.
Cultural
I
respect.
can't see them.
Help us tailor services to their needs, to link services. It's an identity and a history rather than an observable trait. Someone says we have to because of demographics. We want to report data.
Yeah, because all those things are right. And what are...
Here's a good one. Scared of saying the wrong thing.
Yeah.
When the response to the who's uncomfortable when we're asking these questions, people feel, scared of saying the wrong thing.
Yeah, and you know what? I think that comes from what I was saying before about my own journey as a white woman. And there is a deep fear in Australia, and I think it's because we've never acknowledged this country was never Aboriginal, the whole land's sovereignty was never ceded. We know that. It's about it was colonized. It was not, it was a takeover. It was a war, and there was resistance. And I think white Australia has never really acknowledged that. And we have that fear because we know there's scores still to settle. And I think to close the gap, we need to know who Aboriginal people are. And the first person said, it is respect. And when I did some work with a phone line, they weren't asking people. I pranked this phone line and I said to them, I'm going to prank you. And the manager said, okay. So every time I did training with Aboriginal health practitioners, I pranked them. And they did work. And I said, would you use this service? It was a sexual health service. And they said, yeah. No. They said, no. I said, why not? So they haven't asked us if we're Aboriginal or Torres Strait Islander. And sometimes people don't understand that that's actually a respectful thing. It's a mark of pride that you're part of community. And we're frightened to say that sometimes. I didn't understand that. I didn't understand. And I didn't think of that until they said that. And that's it. Because I'm a bit stupid sometimes. I don't understand it. It is a mark of respect. We need to find, me as a data person, we have to find the data. We have to find where people are so that we can respond to it. And often people aren't asked. And sometimes I've found, like traveling around the vaccine van, a lot of the time it's because people are afraid to ask because it's the white people that say, what are you asking me if I'm Aboriginal? But that's actually a really good thing to say as an opportunity if you get that response to engage with them about that question. Why does that question bring some, isn't it a mark of pride? Or whichever way you want to say and engage with it. So actually it's an opportunity for people who are not Aboriginal to engage with that question and to explore yourself. So, yeah.
Thanks, Anne. Someone's likened it as well to asking people pronouns, which can also sometimes be uncomfortable, not necessarily for the person being asked, but the person asking. Yeah.
And I just reflect on yourself. Where does this uncomfortability come from? And I think we're just a bit scared. We may not have met many Aboriginal people. And that, you know, I'm really privileged to work in a Black organisation to do that. And every day I do that. So I have done it. Sorry, everyone. An Aboriginal colleague of mine had told me that in communities where racism is still rife, Aboriginal people feel that the question is putting them in a box. That's true too. So people can choose not to identify, of course. So that's all, but you've got to ask them to give them the choice to do that or not. So yeah, I'm going to stop talking now and I'm going to introduce you to one of my beautiful colleagues, which is Kylie. You can turn on your screen, Kylie, now, I think you're allowed to. Turn on your camera. Yay! Hi, Kylie.
Hi.
Kylie works for one of our members. VACCHO is a member organisation, so we have a whole lot of members, and they're all Aboriginal community-controlled health organisations. Some of them are not health organisations. Some of them do other things. Kylie works for, the word we're wrong, Elderly and Community Health Service based in Portland. And Kylie is an Aboriginal health practitioner. And what we're going to do today, we're just chatting to Kylie because we're just going to do it like a yarn. We're not going to do a PowerPoint because I think that's really like, sometimes you have enough of them today. So what we're going to do is you've got a chance to ask Kylie questions, but I'm going to put it over to Kylie first just to introduce herself and her role and her service.
Yeah, hi, so my name's Kylie. I'm an Aboriginal health practitioner at the Wurrung Elderly Community Health Service. So what my job is to actually do is to assist the GPs, do care plans, take bloods, well, basically help with procedures, do programs and projects. So we're all over the place, just even setting up a room today, like being so busy. We got a new ENT doctor coming in, so I've had to set all that up and get the cameras and all that all sorted. So basically I keep everyone on their toes. I do medical orders for, medical supplies. I don't have one probably job in a medical clinic that I don't do. I'm even there to assist the nurses as well and have them organised, I think, half the time. And how we do about our screenings for the STIs through our clinic. So I generally will see one of our patients before they see the GP out of our mob and do a 715, which is an Aboriginal health check. And during this, we ask them multiple questions, obviously getting their consent, not being shamed about it, don't hide about it, and just come out and go, hey, you're doing this screen, I've got to grab a urinalysis, how about we just test it for an STI? I said, you've got to look after yourself and your body. This is basically all where, you've got to look after you. And generally, they'll say, yeah, 99% of the time that, I just make them so comfortable and being part of the mob that they just say, yep, no worries. So it's pretty easy for me. I wouldn't expect it to be that easier for the ones that are non-Indigenous that don't have health workers within their facility. Therefore, you would have to make the room cultural appropriate, be respectful, maybe get to know them before you ask these questions. So maybe on a second or a third visit. That way they can start making a report. Also, it comes down to men's and women's business. Instead of holding something within our medical, we'll take them down and have like a day, like we've got another building in Portland down at Julia Street, which is one of our places we like to go and relax and feel free. So generally we take in terms of using that building for men and women's business because it's quite shameful. By shameful, I mean embarrassing. So we keep our business separate. So therefore, one day I'd send the doctor down there and have my uncle take the boys down there for the men's shed or the men's group. And, they'll have the doctor and they'll do their own personal screenings down there. That way, they're not coming up the clinic going, oh, well, what are you here for? If someone else from the other mob, Yeah. So, because it's quite embarrassing. And the same with the women. So, we want it very cultural appropriate. So that's how and just explain to them why do you have to do these tests and say it in a way that they'll understand, oh, sis, all this is going around. And if you don't get checked, you're not going to know because sometimes there's no sign and symptoms. So it's just better off to check yourself. Even if you have that regular partner for 12 months and you've been together for years, still get checked because you're looking after yourself and just be open and honest. Don't lie. Because obviously there's a lot of drug issues around that's, and alcohol and some, especially with, all the ones that are on the gear, they'll do anything these days to get the gear if they've got no money. And sometimes the only way we can get hold of them is through men and women's group if they're happy to go. They won't come to the clinic. So, yeah, basically that's what my job does revolve around, including all the health work services. And then I, see the elders, then I also deal with all the chronic diseases, you know, the ITC and QMAX. Like, yeah, I just work in a whole range of stuff that I don't have one set job. So I also go visit the elders and do medication Webster drop-offs and make sure that they're okay. I don't know what else to say.
Just a question. Gear means illegal drugs or, yeah. Yes, absolutely.
Yes.
Yeah, so when
Yes,
I talked to Kylie today, she's in the middle of driving someone somewhere, organising the ENT to come to the clinic, 20,000 things. So when you have an Aboriginal health practitioner, can you explain, so what's the difference between an Aboriginal health practitioner, Kylie, and an Aboriginal health worker?
Okay, so when you're just an Aboriginal health worker, you're just still learning, training, getting on your feet. So first you're meant to do the Certificate 3, which I did my courses through VACCHO, amazing mob down there. And then you just work your way up to a Cert 4. And once you start getting into the Certificate 4 of an Aboriginal health worker, you complete your course and then you're pretty much confident and know your job. You should know your job role if you've been trained and taught, and you know the nurses and doctors. You've really got to have a good team to have, you know, for them to have your back. And I had a really good team to teach me. And to become an Aboriginal health practitioner, obviously you have your Certificate 4 in Aboriginal health, in Torres Strait Islander health, and then you have to register with APRA. And after you register with APRA, they want to know all your ins and outs. And after months later, they'll go to their board and then you will get your practitioner, which just puts you up on a higher level. With a provider number, then you get your provider number from Medicare, and then you can actually claim with all the visits and services of a percentage that you do see with your practitioner license. Yeah. But it's a lot of hard work.
Yeah. A lot of hard work. It's worth it though. Some of what VACCHO is trying to do is raise the profile of Aboriginal health practitioners in Victoria, because if you work across Australia, Aboriginal health workers and Aboriginal health practitioners have all different scope. Georgie's going to say something. Come on, Georgie. Do you want to introduce? Georgie's another beautiful Gunditjmara woman from Gunditjmara Health Service.
Hi, guys.
Hi, Georgie. Did you want to say something?
Just basically, Kylie's hit it right on the head at the moment.
Yeah. Thank you, Georgie. Cool.
Yeah, and like the role of the Aboriginal health practitioner across Australia varies a lot. So sometimes it's Georgie has just recovering, and it's really nice of you to turn up, Georgie, because Georgie's been unwell. But the role of the health practitioner across Australia varies widely, and VACCHO is doing a bit of work with the Poisons Act in Victoria to expand the scope of practice, because sometimes it's been restricted in Victoria, which is really weird. And the role of Aboriginal health practitioners to engage mob are really important, a key role within any health service, but not every health service has an Aboriginal health practitioner in the health clinic. So just each service is really, just to let you know that we've got Georgie from Gunditjmara Health Service in Warrnambool, and Kylie from D-Word Warung, it's a shortened version, DW for short, in Portland. They do, but not everybody has it. So each service actually does it slightly differently and might do their Aboriginal health check slightly differently as well. What about, Georgie, in terms of sexual health checks, do you do them all at the clinic or do you do them elsewhere as well?
We do both at the clinic, but we do like the Clontarf boys through school, and we took them down to Harris Street a couple of years ago, and we had one room with all the health workers in, the practitioners in to do the health assessment. We had the doctor in another room, and the boys, we thought, oh yeah, the boys won't come to the girls. We had more boys on our side than what the guys had.
So how does that work, men's business and women's business then, Georgie?
Because I think it's because they've grown up with us, We've done their health assessments all the way through. So they know us, they trust us. And that's the big thing. You need trust. That whatever they say stays in that room, unless it's vital for their health. Otherwise, we'll tell the doctor. But you just got to get their trust. Even with the sexual health part. I had one young guy, I said, about sexual health, and he goes, I've got something on my little bag. Do you want to see? No, that's for the doctor. That's how comfortable you get when they're talking to you.
Yeah. Right. It's really interesting, isn't it? So relationships are everything, and your ability to zip your lip as well in sexy health is number one. We had a question. I don't know who, Kylie or Georgie, wants to answer this. Is there any similarity to nurse practitioner?
Any similar? Well, yeah, we basically do everything like a nurse. It's just that we're not a nurse. We do everything a nurse does. I think I do more here than what the nurses do. They're too busy doing their care plans and all the other bits and bobs. And I basically run the clinic and help the doctors and do everything. So we basically do what nurses do. It's just that we're not nurses.
I suppose the difference between nurse practitioners is now they can actually give out medications and prescribe, say, Hep C, for example. So that's not something that you guys can do yet.
We don't prescribe medications. I mean, we don't just prescribe. We don't hand out stuff like that unless it's come from a Webster and you'll see an elder. It's different. But no, you can't just go out and give someone their medication.
Great. We've got a couple of questions coming in now. Keep them coming, everyone. So are you able to order STI screening, or is that something you can do in conjunction with the GP?
That's done with the GP. So we only just go through our health check and we tick the box with our health checks, or if they have specifically come in to see the doctor for that reason, we will document. And I normally see the GPs before our mob goes in. I'll go, look, I've got, this young lady in, or this young fella who, he's got this concern. Can we, he wants to be stuff sent off for STIs and he wants to be checked. And, and then I pop out of the room. So they can either come in themselves, or we just ask the question, like Georgie said before, like we've just, for us, they've known us, and, we've got no shame to ask that question because we've got their trust. So basically through the health checks, we normally get the STIs, unless they've come in with concerns and they're willing to open up to us and go, I really need to see the doctor. And then, so we'll, get it done straight away. But
okay. What about, because we did one training session and people said, oh, you wouldn't bring someone else in with you. We showed a video of Young Deadly Free, of a young person coming in with their partner to get a screen. And I remember one health professional saying, oh, that's really bad to do that. I'd never do that. What do you think about that?
I remember that. Yes. It's their own choice. If they come in as a couple and they've got no shame and they feel comfortable with their partner there and that's okay with them, then they can, sit there. Why can't they? They're together all the time. But generally they will come in on their own. But otherwise, if they're bringing their partners in, they'll bring them in.
It's their choice.
But you just got to ask, if it's okay for you to sit there, is it okay to have them in the room? Yes, that's fine.
How do you deal with family members coming in with them, like their mum or their auntie or their cousin?
Being the young ones, I generally try and pull, especially because normally they come in with the mums anyway. So I generally pull the mums aside saying, hey, during the health check, because your child's going on, well, even now it should be changed from a bit younger, but because your child's going on 15, 16, we're actually going to do an adult health check today. There is a question I'm going to need to ask. Would you mind hopping out the room? Because having mums in the room, they're going to go real shame and they're not going to say nothing. Because you don't know, they're definitely not going to say, oh my God, I don't want mum to know I'm not a virgin or this and that. Because, when you have that chance and that talk and then you say, oh, okay, have you spoken to your mum about this? And oh, okay, are you on the pill, or do you need, you know, are you using protection? Have you, and if you haven't, can we send stuff off for, you know, an STI? Like, you just, but you have to make them feel comfortable with you first. But definitely ask, you know, for the parents if it's okay to speak to their child alone, still being younger than 16. It's just out of respect.
Yeah.
Yeah.
So another question was, I'm just starting my journey working with Aboriginal youth and sexual health. Are there any lessons you've learned about working with youth in particular? So we talked a little bit about coming in for a sexy health check. Is there anything else that either of you would like to say about working with young people?
Just be mindful and respectful, and just remember they're more shamer than us being as grown women or grown men. Yeah, and just make them feel safe, like, so that, you know, they're able to talk. You know, make sure you can earn and gain trust, like, instead of saying, oh, well,
and how do you actually do that, Kylie? How do you actually make sure that you build that trust with them?
I don't know.
Is it because they know you're already from
a bit like the same. Like, we know the mob. We've, you know, this is our country. We've grown up here, so they all know us. But we still have to gain trust. It's just knowing that they can confide in you. Like, oh, and you know they
and the
will
confidentiality.
Yes, and they'll come to you and go, oh, hey sis, I need to, you know, have a yarn with you, or hey sis, I've got this other sis or bros that needs to come have a chat. Is that okay? And they'll just like, I'm like, yeah, you just got to make them feel comfortable. Like, don't make them feel ashamed or say, oh, well, you're this age and you shouldn't be doing this and having sex and unprotected. I mean, if you say that, they never come back to you. So just be honest. I don't know if Georgie has got something to say, but yeah.
Look, honesty is the best way to go. You know, especially with the young ones, you know, they go, oh, why do I have to have this test? You know, why? And I said, look, I've been married for 36 years. I still get it done every year.
Yeah.
And they go, why? And I keep saying, I want to protect myself. Some things are asymptomatic. You don't get no symptoms. Oh, okay, we'll go for it then. You know, it's just the way you put it.
Making it normal and not making it like, oh, you look like not. So the problem is sometimes we do risk-based assessments. So we think, are you doing anything with the sharp and pointy? Are you doing that? Are you doing 20 questions, right? So it's really tricky about asking a sexual health history, because sometimes it is really important to know what sort of sex people are having so that you can actually work out what tests to have, which swabs to do. But it's also about normalising it as that sexual health is health. And I think Aboriginal health services do that really well. And I think we need to, my whole role at VACCHO is to celebrate the work that you do and the expertise you have. Not only are you amazing health professionals, but both of you are part of the Gundi Chamara country. That's your mob. So you're juggling all those things, and it's not to be understated how difficult it is to actually work as a health professional in your work life, and also continue. Often people will probably ask you things in your private life as well, because you have that knowledge. So you have an enormous expertise that needs to be celebrated, and that people are very unaware of the sort of amazing work that you do and how important your engagement with communities is, because a lot of the doctors that work in Aboriginal health are not Aboriginal, and many of the nurses are not Aboriginal, because we're still trying to build up that workforce. So people may not know that. So the role of Aboriginal health practitioners are even more important, to understand mob, to have connections and social understanding. And the main thing that both Kylie and Georgina have said, Georgie said, is trust. Sorry, I'm backtracking and I'm talking too much. Stop, Anne.
One thing
you go for it, Anne.
We do at our clinic, is when we have a new doctor, they are, if it's a female doctor, they will get put with the female practitioners, Aboriginal health practitioners, and we'll do cultural safety. So if they've got anything that, you know, they need to ask us, you know, if someone, like one day someone went, oh, butcher. And the doctor goes, what the hell was that? You know, learning our lingo is another thing, which is cool.
Do you want to tell them what it is? It's female private part, mucha.
Yeah.
Someone was talking about mucha Sahara the other day when they were talking about menopause.
Yeah.
That made me laugh as a person who's going through menopause, or, you know, I know I'm only 36, but yeah. We've got another, sorry, Georgie, what were you going to say?
No.
All right. So another question is, are hospitals required to recruit registered Aboriginal health practitioners to their Aboriginal hospital liaison positions?
No.
Are they required?
I'm not sure of the legal requirement. If that question, Alinda, is meaning.
They're just got to be Aboriginal and be known in the community.
They're identified
As long as-
positions, so each hospital. Yeah.
It's best to have one from, you know, their mob area if they can get one, just so they can have an Aboriginal liaison officer they'd like to go to, or a practitioner, just so that, you know, when they go to a hospital, they're going to feel comfortable, whether they're going in there to see a specialist or to have surgery or just, you know, a prenatal checkup. Like, you know, for them to have a connection with someone coming into the hospital and having someone there from their own mob where they've got their own little area and have a, you know, cultural connection with a little section, that means a lot to them. Like, to make our mob so comfortable, because it's really hard to get them to the hospital in the first place.
Tell me more about that, Kylie. Why is it so hard to get people to hospital?
Oh, well, with the elders, I think they're getting sent there because they're not going to come out because they're going to die. So, you know, that we suffer with a lot of chronic diseases and illnesses around here. And then the young ones, like, it's hard enough sometimes to get them to the doctors, let alone to the hospital, because they're like, oh, you know, but if they go in, they haven't got time to go in. They're, you know, they're too busy doing something else, and then they just wait until they're chronically ill.
So they put it off till they're really sick and
Most
then
of the
go
time,
to hospital.
Most of the time, but not all of us. Not all of us. There's a lot in the mob that are good, that, you know, like, if you can get to them early enough and get them to look after themselves, like, and explain to them why they need these checkups and why you're doing this, so they understand. And, you know, if we've got to go with them to these appointments to make them feel more comfortable, that's what we'll do to make them go.
And it's a bit like that fellow that nurse was really excited to ask him all the questions. And he said to her, oh, when are you going to take my statement at the station? And she didn't understand. He was red flagging to her, look, just back off. You don't know me. I don't know you. We don't have a relationship, but you want to go straight to the really sensitive part.
That's it. And see, they don't want to, you know, be talking to someone else, neither they don't feel comfortable with. So, you know, just to have someone, you know, from our mob that's there to make them comfortable. And, like, understand a lot of services still don't have this, or, you know, I mean, I lived up in the desert 4 years and there was nothing up there, and there was no support. There was nothing, no civilisation, like, and they wouldn't even know what an Aboriginal health practitioner was. And even I tried to get a job at the clinic there, you know, with the mob that were up there, and they just had no clue. And I'm like, you don't understand what you're doing. Like, you know, they either don't understand or, well, why do we need one? So,
yeah,
I just think more of us out there and around the place, like, you know, it'd be better for the community.
Yeah. Beautiful. Did you want to say something, Georgie?
No.
No. Okay. So the other one, is there a reason why not every clinic hospital setting doesn't have an Aboriginal health worker or practitioner? A funding issue, or people doing the training? It's all of the above. Training is really important. VACCHO does a lot of training, but there is in sexual health, there is one FTE in sexual health, and that's at VARS in Melbourne. a lot of people don't get proper training. Kylie and Georgie are really at the top of their game in terms of being health practitioners. We need to respect and honour their expertise. We don't get funding for specific sexual health positions. We have one FTE and there's me in the entire Strait. And the entire sexual health workforce is it. And so there is no KPIs in sexual health. So NKPIs are basically what you're funded to do. And so both Georgie and Kylie fit sexual health into all, like Georgie, well, how many jobs do you have? Like health promotion, NDIS, everything else. And Kylie as well, like doing 20,000 other jobs besides sexy health. So I pulled her away from the clinic to do this session today. And no doubt both of you are, Georgie's on leave. Kylie's probably going to run around trying to do like 50,000 things after this going, oh my God. So we've just got to be mindful that, we don't fund positions. They run off their feet. So you've got to remember that when you're trying to engage with Aboriginal health practitioners, it might take a while because they've got a lot on their plate. The other person said, in mainstream health services, they're supposed to be very aware of the possibility of a partner using coercion and control against their partner. Do you have suggestions about balancing respect for couples wanting to come in together and the need to protect people from having their partner use even their sexual health consultation as another form of abuse? I'll just put that to you, Georgie, a little bit, just in terms of, yes. I remember having this conversation with a sexual health physician, and you said, often I go in with people to hold their hand.
Yes, you do.
And so, the role of an Aboriginal health practitioner has the knowledge of community as well. And often, them coming with their partner is actually fine, generally,
yes,
if they want it.
But you basically just got to ask them, are they, and you can just look at the person and you'll know if they actually do want the person in there or not. You can just look at their face and you can see in their face. And then that's where we've got that latitude of, look, he wants to be here, but can you just move away a bit? Yeah. We kind of manoeuvre them like, oh, you want to go speak to the male health worker, she wants some private time. You're going to be both still in the same building, but she needs this by herself. I'll be here, and if you need, I can talk to you later with her permission.
Yes.
It's just, you've just got to try and manipulate it around so that all parties are happy.
Yeah.
And it can be tricky.
Yes.
But that's the skill that you have, Georgie and Kylie, to know that. And it's also like, it's not what's said, it's what's not said that you read between the lines as much as what is said. And it's a skill that you hone through your practice. It's not just off nothing. It's also local knowledge because you know community as well. So you might know something, but you zip your lip, not like you're saying anything as well.
Yeah.
But it's your keen observation skills as a clinician.
Because you can read it. You just, I think that's one clue with us. We can read our mob. Just their expressions, they're just their little traits they've got. We know when something's not right. So we put it in place.
Okay, I'm mindful that we've gone to time.
I was going to say though, Anne, that it is a break time now. So if you were wanting to stick around for another 10 minutes and answer some more questions, that's perfectly fine. But then if people did need to go, this is an allocated break time.
Okay, I'm going to have to leave. I'm going to have to leave for the day, but I'll leave my email in message. So if anyone's got any questions or they'd like to contact me.
Thanks so much, Kylie.
Thanks, Kylie.
Thank you so much, Kylie, for fitting us in. You're awesome.
Yeah, that's okay.
And Georgie,
thanks for taking my place.
You've come in on leave. Oh my God, how dedicated is that?
Oh, I'm painkiller enough.
Oh God. Oh my God, we got looked after so good. We went to Gunditjmara country last week with the vaccine van and we just had a ball. It was so fun.
So much.
Thank you very much. It was so lovely.
It was so much good feedback too.
Oh, that's good.
Yes.
That's really good.
And I'll call you later.
Thank you,
Anne.
everybody. Thanks very much. I've got to go too. So thanks, CERSH, for inviting us. I really enjoyed it.
Great. Thanks, everyone. That was really great.
Bye.
And we do have another break now. We have a lunch break until 1:30, where we will return here for some more fabulous presentations. Thanks, everyone. Good afternoon, everyone. Welcome back from the break. I hope that you had a nice lunch. I would like to introduce now from the Centre for Culture, Ethnicity and Health, Kanwal and Tapuwa, who are speaking on engaging with refugee and migrant communities on sensitive issues. For those of you who are just joining us for this afternoon, I just wanted to remind you that the Q&A function is in use if you would like to ask any questions. Thank you.
Hi, everyone. Let me just share my screen with you all. Just a second. Yes, here we go. So thanks, Ashley. So my name is Kanwal Saleem, and I have my colleague Tapuwa, and we are from the Center for Culture, Ethnicity and Health, and we both work as a community engagement and projects officer. Today, we will be talking on how to engage with refugee and migrant communities on sensitive issues, such as sexual health, bloodborne viruses, and sexually transmitted infections. Before starting our presentation, I would like to acknowledge the country. CEH respectfully acknowledges the Kulin Nation as traditional owners of the land where we deliver programs and services. We acknowledge the Aboriginal and Torres Strait Islanders as the first people of Australia. Sovereignty was never ceded, and they remain strong in their connection to land, culture, and in resisting colonization. A bit about us. So the Center for Culture, Ethnicity and Health, or CEH in short, we are a part of North Richmond Community Health. We work with communities professionals from health, community, and local government services to improve health and well-being of people from refugee and migrant communities, and that also include international students and people on temporary visa. So as we all know, that Australia consists of a multicultural population, and over 1/3 of its population, that is approximately 30% of people, are born overseas. These people are usually comprises of communities who are refugees and migrant, and these have over 200 plus languages, which means that what may be appropriate for one community group or one individual may not be appropriate for other community groups. Considering this, sexual health or sex is still a taboo in many cultures, and it's a very sensitive topic to talk about. So engaging with these communities poses unique challenges. So in today's presentation, we will be talking about some tips and strategies on which may help you while working with these communities in your workplace or in your organization. Before we jump to the tips and strategies, we would like to discuss what do we already know. So we know that, and research shows that people from migrant and refugee communities are actually at a greater risk of getting sexually transmitted infections, such as HIV, hepatitis B, chlamydia, gonorrhea, etc. However, despite this fact that there is a higher rate of infection among these communities, there's an underutilization of the available sexual and reproductive services. And these services include interpreter services as well. And this can be due to numerous socio-cultural beliefs, stigma, shame, and other cultural beliefs. In addition to that, there's also poor access to culturally relevant information and familiarity with preventive methods and treatments. Now, this can be due to the fact that some people don't even know what kind of services exist already or how to access them. In addition to that, and the most important thing is when when these groups migrate to Australia, which is a whole new country and a new environment for them, there are numerous resettling issues which involve housing, finances, employment, and other issues where sexual and reproductive health may not be a priority for a lot of these groups. So what can be done on our behalf, like on our, from our area to engage with refugee and migrant communities? And in short, how does engaging with refugee and migrant communities look like in action when we are on the ground? So the most important one is know your audience, or know the community group you are working with. Knowing the communities actually will help you understand what people or that particular community care about, and what are the specific cultural issues related to sexual health, or what are the sexual health issues in that particular community. Because obviously in some community groups, HIV is more prevalent, in some communities, chlamydia is more prevalent, in some communities, hepatitis B is more prevalent. So you need to know your audience, which community group you are actually targeting your program, your session, or your workshop towards. The other thing is this: knowing your audience will actually help you tailor your program, because no one size fits all. You need to have tailored specific projects and programs for each of these communities. Also, engaging with some populations may require support and approval from the community leaders to access that group and to work with them. I'll give you an example. So this was one of the session which we did with young girls from Muslim community, and this they were of 9th and 10th standard. We delivered this session on sexually transmitted infections during the sexually transmitted infection week at a school, and at an Islamic school. But we had to actually follow a process. To actually deliver that session, we had to go through a lot of people, which involved principals, community leaders, permission from parents to actually deliver a session, because in that community, talking about sexually transmitted infections is not that common. We then tailored our presentation according to the needs and the cultural beliefs of that community. We included a lot of references from the religion, a lot of references from the culture, so that our presentation may not offend them. However, also in the end, the presentation and the session was quite very well received, and it was a very successful session. It was attended by around 130 students, and we got very positive response. So this was one of the examples of how knowing your audience and tailoring your program towards that particular community is important. The next one is choosing the topic. We don't really have to use the words like sex, sexual health, reproductive health, hepatitis B, HIV in our workshop or a session or a program. We can easily promote it or name it as an health event like women's health or men's health or a well-being session. Because in some communities, having words like sex, sexual health is not considered appropriate, and just because of that reason, they may not attend the session overall. So this is another example. So we delivered this session to young Chinese students, and it was around hepatitis B. But as you can see, our topic was, is your liver as healthy as you think? So the title didn't have hepatitis B mentioned anywhere, but the session was on hepatitis B. The title was quite catchy, and there were a lot of registrations. There were a lot of people who attended it. And as you can see from the picture, they quite liked it as well. Tapuwa, do you have anything else to add?
Yeah, maybe if we can go back to selecting the topic. I think a number of organizations are beginning to get the grasp of this idea, especially when we are talking about domestic violence. People rarely use the phrase domestic violence anymore. They would prefer to call it maybe health relationships or respectful relationships. what they are trying to avoid is to go direct, like talking about sex directly. So most of these communities would not be very comfortable with sex being mentioned quite openly like that. So choosing your topic is one of those strategies that is working very well in most organizations.
Yeah, thank you so much, Tapuwa, and I totally agree with you. Okay, so the next step, training peers and people from the communities. So this is something which we do in CEH a lot, and it has been quite successful. So being from same cultural background can make conversations very easy. So a lot of people actually feel very comfortable when the facilitator is from their own community, when they look like them, when they speak the same language and have the same cultural backgrounds. And that actually helps to build that rapport, which breaks the ice. So the example. So this was a session which we actually delivered to Latin women in March 2020. It was on HIV and PrEP, and this was delivered by a Latin woman herself. And she delivered it in Spanish. We trained her, but the whole session was facilitated by her. At the end of the session, we had this condom demonstration activity, which is actually a not very comfortable activity, and not all the communities and all the audiences are comfortable doing it. But at the end of the session, we kept it at the end of that session. And as you can see in the picture, the young Latin women were quite comfortable. Initially, they were quite hesitant, but then when they saw the facilitator was from them, she was a Latin woman herself, and she initiated, like she was talking about it, she broke the ice, she made them feel very comfortable, she provided them with a safe space where they can talk about it, where they don't have to feel the shame. They all felt really comfortable, and in the end, they all had tried their hands on the activity. Now, I would like my colleague Tapuwa to continue with the next strategy.
This is a very important aspect in terms of sexual health education, where facilitators are generally encouraged to have to segregate, to put them in groups based on their gender. So gender segregation sessions provide a safe space and encourage people to ask questions about topics they generally feel shame about, particularly on topics such as menstruation, erection, and sex. So when we are talking about these communities, the majority of them are quite religious, and they have got very strong religious beliefs, which we are not supposed to ignore. I think Kanwal talked about understanding the communities, and we should also know the gatekeepers, and these gatekeepers can actually provide us with some of these strategies. If you consult them, they will tell you how to deliver these sessions. So if, for example, if people are not segregated, it can be very challenging, especially when people who are related are in the same group. That can be very disastrous. So it is always encouraged, especially on sexual health topics, to separate male and female. And preferably, it would also be good to have a male presenter for a male group. It is also preferable to have a female presenter for a female group. So those are some of the things that we would normally encourage people to do when they are dealing with these communities. Yeah, I think you can go to the next slide, Kanwal. So this one is as you can see, it's a female group. So they are discussing some options. I think this is to do with family planning as well. And also to add, when you are doing your research about these communities, there are certain things that can be taboo. For example, if you're talking about pregnancy, you might want to avoid the word prevent pregnancy in some communities, because that can be very challenging. You would prefer to use the word manage pregnancy, because in some communities it's actually not only a taboo, but also a sin based on their religion. Okay, you can go to the next. Quite a lot is done in order to support communities to understand what is being taught. So the facilitators would generally use audiovisual aids in order to help people from migrant communities whose English language skills are very low. So they might want to use pictures and images, but I think it is also important to mention that these must be used with great care. I would actually recommend, or we would rather recommend the use of drawings rather than the use of the actual image which show the body parts, because they could be very confronting to some of these communities. And once they don't enjoy it, then even proceeding with the session can be very challenging as well. Then the other issue, of course, is to engage professional interpreters to talk about some of these things. But it is also vital before the session that you talk to the interpreters and make sure that they understand the procedure, they understand the content, because some people might also want to, if it's a very sensitive issue, they might not provide the actual information. And then it is always advisable not to use community members as interpreters as well, because they might choose what to give the people and what to leave out and what to include. So it's a very important thing. So the bottom line here is, of course, when you are using images, try as much as possible to use drawings, try as much as possible to avoid the actual images that show the sexual body parts, because they can be very confronting to some communities. You can. So this is a group of Arabic-speaking communities. Obviously, an interpreter would be required for a group like this one because their English language skills are very low. But one thing to consider as well is when you're talking to young people, especially those who were born here, obviously their English language skills are a lot higher than the parents. So those are some of the things to consider as well. There are some communities, I'm talking about, say, for example, the Somali community, they have been here for more than 20 years. So if you're dealing with the young people, the chances are that the majority of them were actually born here, and their English language skills would be reasonably good. But then if you're talking about the ages of the people that we see in the picture there, definitely an interpreter would be required. All right. The other important aspect is for organizations to be culturally competent when they are supporting supporting community members. I always prefer to use the word support rather than help. So if you are supporting, you are also recognizing that the people that you are supporting, they actually have a bit of capacity. So we need to understand they have some information, basic information. So what we are only doing is to add on to what they already have. So, but then there is a process that is supposed to be followed in order to deal effectively with these communities. Intercultural communication skills that would help you to understand more or get more skills in order to deal with newly arrived or even people who have been living here for some time, but whose culture is quite different from the mainstream Australia. Okay, you can go to the next one.
Yeah.
We at CEH as an organization, we actually provide a training. When I joined CEH myself, I participated in quite a number of these training programs, and they helped me quite a lot when I go out there to talk to different communities. Communities are quite different. You're talking about their demographics, you're talking about age, you're talking about gender, So how to deal with these particular communities, you really need to be culturally competent in order to do that. So I think our organization, if you belong to an organization that might require this kind of information or this kind of training, I think there's a process for you to follow, and then our organization will definitely be in a position to support. And we have got some testimonials from those organizations that have received our training. Of course, in that slide, you can see the city of Dandenong. We provided training there, and they gave us a glowing testimonial about the training. We also have Core Health, and I think they were formerly known as Western Region Center, Western Region Health Center, and now they are called Core Health. They also gave us glowing testimonials about the training that we offer. Then the other one is family care, is almost the same thing. So what we are trying to encourage people is to do the training in order for you to have a deeper understanding of how to support or how to engage with these different communities, especially on sensitive issues like sexual health, STIs, and other conditions. But me coming from a migrant background myself, there are quite a number of things that I really didn't know when I came to Australia. And we are also talking about people who sometimes in their country of origin, we are using traditional ways of getting health. But when they come here, it's a different story altogether. So they need also to be supported to navigate the Australian health system, which is very critical. But I can give you a very quick example of somebody who wanted to, he actually went to the doctor, and the doctor gave him a prescription, a note, which was written, repeat. He could not even understand. He was a well-educated person, but he didn't understand what that repeat was talking about. So we also talk about these things, how to drop the jargon when you are dealing with communities like people who are coming from migrant and refugee background, dropping the jargon. Okay, you can go to the next one, Kanwal. So that's the community talking about us as well. I can read the first one. Excellent session. The presenter was very good and gave a very clear presentation. Also having the session in our own language. I think we mentioned this earlier on, that sometimes it's very critical to invite people from those communities. They can explain a lot better than us who might be explaining in English. So because the person was explaining in Mandarin, it made it simple and easy to understand. So those are some of the testimonials that are coming from members of the community. Do you want to go next slide?
Yeah, sure.
That's a very excellent statement. People normally talk about capacity building, and here we are talking about nothing about us without us. Nothing about us without us. It's a slogan used to communicate the idea that no policy should be decided by any representative without the full and direct participation of members of the group affected by the policy. So what we are trying to do or to say here is that we need to invite everybody to come to the table, and whether we are going to form a program or project, there need to be involvement of the community members themselves, sometimes through their gatekeepers or sometimes through their own representatives. So nothing about us is just a question of trying to encourage people to involve the members, to involve the communities that you are supporting. And this can also be covered through the training that we mentioned earlier on, the cultural competence training. They do cover issues of community participation as well.
And I would also like to add here that it's a great idea to actually co-design your programs, your services and projects along with the people from particular communities you are targeting those programs towards. It's always a good idea to actually have their feedback on it. It's not just having a program plan and asking them like, okay, do you agree with this or not? But actually involving them from the beginning, having their say incorporated into your plan from the beginning, asking them like, okay, so how would you like to work? How would you like to work on this particular topic or on this issue?
Yeah, I can also add something there, Kanwal. I actually remember when I was working with some communities, and the one thing that they did not like at first was the sitting position. They didn't want to sit in rows, some people sitting behind them and some people in front of them. They actually opted for a circle. And when I asked them why they preferred that kind of setup, they actually said, this is what we normally do in our own countries. We sit in circles, and if you could allow us to sit in circles, I think that would be very helpful. It was, for me, it sounded a bit minor, but for them, it was a huge thing. And when I accepted, they were quite happy for us to proceed.
And same goes with the food, actually. Like if you are organizing a session, usually you go for like frozen stuff or maybe pizzas, and because or maybe like finger foods, which are very easy to eat. But in some communities, they don't like that kind of food. So I had I'll share an example. So I had done a session with the Chinese community, and the first session we just kept pizzas, and like at the end, the food was like everything was left on the table already, like just like the beginning, and nobody actually ate anything. And then I asked the peer ed, like what went wrong? Is it not good, or like what's the problem? Why are people not eating it? And then they were like, because usually we prefer things like maybe fruits and like healthy choices. So in the next session, we actually kept fruits and all the things or all the food items which they have suggested. And yeah, it was a success. All right, so next slide. So this is actually a website which is, so CERSH has recently designed this website. This is, it's strictly focused on STIs. And this was designed for the STI testing week 2021, which was in October, but it's still live. And this website has all the resources and all the information you would require for STI, all the information about talking about STIs, how to feel comfortable, and then testing, how to get tested, and treat, what kind of treatments are available, where to refer your clients or your community members, or what kind of treatments are available even for HIV, for hepatitis B. So yeah, please do visit the website if you need any kind of information. So the website is talktesttreat.org.au. And that's it. I think we finished quite quickly. So yeah, thank you so much for having us. And sorry, so it's time for the Q&A, and we have a few questions in the Q&A box already. So yeah.
Thanks so much for that presentation. That was great. Did you want me to ask you the questions?
Yeah, sure.
Okay, great. There's two questions that are quite similar.
Yeah.
And they came up when you were talking about gender segregation in the groups. So the questions are, when you're considering cultural sensitive practice, where this overlaps with trans and gender diverse issues and gender and sexual diversity, how do you manage that when it's so separate, the men's and women's business?
Yeah, great question. And I think I'll ask the second question as well, and I'll answer both of them together.
Sorry, I just summarised them. I'll read the first one because that's the one I didn't really read. It was how do you reconcile inclusivity of gender and sexual diversity in gender segregated groups without potentially further alienating an already marginalised group in some of these communities?
So that actually great questions. That though both of those questions are actually asking about the same thing, and it actually takes us back to the first point or first strategy or first tip. Know your audience. Ask your audience. Know the community group you are working with. If you know, because for example, what happens is some community groups prefer having combined sessions, and some community groups specifically ask or tell you that they don't want mixed sessions. So you have to respect that. So I would suggest to just ask. It's always a great option to ask them how and what kind of session or what kind and how they would like it to for it to get delivered, and how would they like the message to get conveyed. Because it's the best to ask them and give them the power to tell you what they prefer rather than you deciding and in the end, maybe offending them. The second question is about LGBTIQA+ or gender diverse communities. So for the gender diverse communities, you can always collaborate or partner with organizations and the small community groups who are already working on the ground. Always look into the collaboration and partnerships. And then once you get the trust and you build the rapport with those communities, then you can have a combined session, you can have a segregated one, or whichever type they prefer.
Can I also add on to that one, Kanwal? What we normally do is when we plan our sessions, the organizers normally request that we send the content to them before we actually deliver the session. So they would, in the majority of cases, they will give us the guidance on how to proceed. So whether people are going to be segregated or not, it will also depend on the people who are going to be hosting us.
Yeah. For example, I would like to give another example. For example, we are doing some sessions with Drum Street Services this week, and it's about COVID and where to get vaccination and what are LGBTIQA+ friendly services or spaces where they can get the vaccination from. And we are doing it in collaboration with Drum Street Services, and Queer Space is also collaborating on that. So it's always good to have those services or those organizations who are already working with those community groups and do something together.
Maybe another additional point, Kanwal, is I actually delivered a session at an Islamic school. So the content was actually looked at by the imam in that school. He looked at the content, he checked the content first before I actually went there. And when I went there, the imam was always present during the session itself. Some of the questions were actually being answered by the imam himself, but he was giving a religious perspective to what I was delivering.
Yeah, thank you, Tapuwa, for that.
That's great, thank you so much. Are there any other questions in the Q&A? No, just some comments. People are just saying thank you so much. Great information, great session learning about cultural appropriateness and respect. I think your response to how do you deal with this, just ask them. It's maybe even going to be a theme for today that, people know what they need and you just sometimes need to ask them those questions.
And it actually shows your respect towards them. It's not that you are like superior or you have more knowledge, but those communities, those culturally diverse or gender diverse communities, they know what they want. They have a clear cut plan, like what they want and how they want it. So the best thing is just ask them.
Yeah, that's great. Thank you.
Thank you.
Oh, here we go. Here's another. Oh, no, someone just saying excellent information. Thank you. Lots of
thank you so much.
Thank you.
Can I ask a question?
Yeah.
When you were referring to the training, on your website, are there free modules that people go through, or are there things that people can sign up for professional development opportunities through the website?
Yeah, so the best thing to do is there are all the contact details on the website. So the trainings are actually managed by another team, capacity building team. So what is best is either email me or Tapuwa, or you can actually direct your email or your answers to your questions to the email address or the contact information provided on the website. And we'll be happy to refer to that team, and they will be happy to answer the questions.
Great, thank you. Just wait and see if anyone else had any more questions. Oh, there you go. And your email address has just been put into the chat. If people wanted to give you an email, Kanwal, thank you. Beautiful. Well, if there are no more questions, I'll just thank you again for both of your time and your presentation today. And I'll refer people again, people who are saying it's great. There is going to be a recording made available if you would like to refer back to this, or there's a colleague of yours that you think might, want to listen to it. You'll be able to do so. So thank you so much, both of you, for your time.
Thank you.
We are running ahead of schedule, and I'm just having a think out loud. Because the agenda was posted online, I feel as though, out of respect for people that might be coming specifically to hear Claudia's presentation at 2:30, we might just take a break between now and 2:30. Yes, but I'll be here around if people wanted to continue putting some questions in the chat or some general comments, then feel free to do so. Okay, thanks everyone. Hi, welcome back. I would now like to introduce Claudia Validum, who is the Program Manager at Thorn Harbour Country. Claudia is going to be speaking to us about considerations when working with the LGBTQIA+ community in the health and wellbeing space. So thank you and welcome, Claudia.
So I hope you can still see me. I've lost all your faces, so fingers crossed.
Perfect, Claudia.
I dislike it when I can't see anybody and I can only see my presentation, but I'm sure it's just one of those technical glitches that happens when you're using the lovely platform of Zoom. So yes, my name is Claudia Validum, and before I start, I would like to acknowledge that Thorn Harbour Country is on Dja Dja Wurrung and Taungurung country. I would like to acknowledge and extend my appreciation for the Dja Dja Wurrung people, the traditional owners of the lands that I'm presenting from today. I pay my respects to leaders and elders, present and emerging, for they hold the memories, the traditions, the culture, and the hopes of all Dja Dja Wurrung peoples. I express our gratitude in the sharing of this land, our sorrow for the personal, spiritual, and cultural costs of that sharing, and our hope that we may walk forward together in harmony and in the spirit of healing. I would also like to say that this is Black land and forever will be Black land. So yes, my name is Claudia Validum. I am a QPOC, which is a queer person of colour. And as some of you may have picked up, I'm also English, so I'm very much a big fruit salad. And I'm the program manager for Thorn Harbour Country. Today I will be talking to you about the considerations when working with the LGBTI+ community in the health and wellbeing space. Before I start, I'd obviously like to show you a video of our organisation. It's a few minutes and then we can press on.
For the past 35 years, change has been the one constant in the work of our organisation. As the HIV epidemic has changed, our organisation has evolved. We are now responding to a broad range of issues that affect the health and well-being of our community as a whole, with issues such as drug and alcohol use, trans health, family violence, lesbian health, homophobia, transphobia, biphobia, and stigma and discrimination.
Whilst you're playing it, Claudia, you might just need to not click on anything else. And that should just go away, that bar.
People living with HIV. Our work has also moved beyond Victoria, with health promotion programs and projects that are national in focus. Halfway through the fourth and hopefully the last decade of the HIV epidemic, the time has come for our organisation to reflect the changes faced by our community, while maintaining the legacy of activism that created us in the beginning. In 1983, at the first public meeting to address the developing health crisis of HIV and AIDS, one voice stood out amongst the many. Feminist and activist Alison Thorne motivated and mobilised the community by asking, "What are we doing about this, and how can we do it?" It was Alison's rallying cry that ultimately led to the formation of the AIDS Council. Keith Harbour became president of our organisation in 1987. A man living with HIV, Keith was a pioneering leader who mobilised the community from high-level political policy to grassroots activism with the AIDS Coalition to Unleash Power, ACT UP. Keith continued working to get access to life-saving medicines for people living with HIV until the day he died. In aligning our new brand with leaders like Alison Thorne and Keith Harbour, we're not simply acknowledging the legacy of our past. We're also recognising that the care, health and well-being of the gender and sexually diverse communities will need bravery, commitment, inclusion, imagination and vision. We are now Thorne Harbour Health, and we will continue to work for the dignity and well-being of our communities, now and into the future. Thorne Harbour Health, for the future.
Lovely. I'm scared of touching. Thank you, Ashley, for pointing me in the right direction. So there's a video about our organisation. Thorne Harbour Health has been around since 1983. So born out of the AIDS epidemic in Victoria. We used to be called the Victoria AIDS Council, VACCHO, and now we are Thorne Harbour Health. Thorne Harbour Country has been around for approximately 5 years. We started as a very, very small support service, branched out from CAN, which is a country AIDS network, and CAN then dissolved and we took over the support of the community and have been building services in Loddon Mallee for the past 5 years. What do our services include? Well, quite a little bit. There's counselling, there's capacity building, which is training, youth projects, AOD, alcohol and other drugs case management, relationship and family violence support, that's a new service coming to us in 2022, therapeutic groups, sexual health services and education and workshops, rapid sexual health testing referral, peer education and a community hub in Bendigo. So the headquarters is in Bendigo, and I do a lot of travel across a lot of Mallee. So we are open to have community organisations, community members use that community hub in Bendigo. So where do I cover? Loddon Mallee, it's a very big space. It's approximately 55,000 square kilometres. A lot of 9 local government areas, so I could be anywhere from the lovely Castlemaine, where I currently reside, all the way up to Robinvale, Mildura, anywhere in between. If you're thinking, oh, there's not really community, queer community in Loddon Mallee, you're very much mistaken. There are a lot of queers and we are everywhere. So if you take a quick look at the map, Mildura, who has a population of 53,800, there is a big pocket of community there and it's serviced through Mallee Pride. And there's quite a good foundation there of community. Swan Hill will have, it's got headspace there, and again, a good pocket of young queer community, which will stretch out down to Swan Hill, Robinvale, all the way up there. Also a great pocket of Indigenous community. I've met a lot of Indigenous queers up there, so there's a lot happening in that space. If we go down further to the bottom, Bendigo with Bendigo Pride, another huge community. Castlemaine has an older queer community as well as Dalesford. Kyneton again, and also you'll find in Echuca and Shepparton, you have Out in the Open, again, another festival and another big community there. So there's a lot of work that's happening in this space. There's a lot of organisations that are working in this space that are mainstream and queer organisations. And there are also some really great projects, particularly youth projects happening with organisations and councils. So what will we cover today? I love my little comedy strip at the side there. Doctor, are you sexually active? Gay woman, yes. Doctor, is there any chance you could be pregnant? Gay woman, no. Doctor, nothing. That's actually happened to me quite a few times. Too many times to count, but there are a few things that pop up. I'll share some of my stories as we go on. But what I'm hoping to cover and support and talk about today is some basic statistics, systemic barriers, what the research tells us, health considerations, intersectionality, and how to create affirmative healthcare spaces. So before we keep going, Ashley, you may have to help me because I can't see participants' questions or anything like that. I'd like to ask a question to the audience. Have a guess. If you're in a room of 100 people, you're at a hip and happening Christmas party, how many people out of that 100 do you think would be from the queer community? Throw it out there in the questions.
What have we got? 25%, 40%, 30, 30, 30, 10, 15, 40,
Ooh.
11.
40
would be a lot.
40, wow, that jeepers. I'd love if it was 40. Got some good guesses there. I heard one that was correct. Here we go, the cake. So heteronormativity as we know it. The slice of that in terms of our community is 10%. That has been shown by research. So out of that 100, you'll have 10% in that room that are identify or may not identify, may not be out as LGBTI. You'll have 2 to 4% that are trans and gender diverse, and you'll have approximately 1.7% that are intersex. So I put this cake in here to remind people that you may not on your day-to-day meet a lot of people from the LGBTQI community, but they will be there, whether you know it or not, whether they're out or not, whether it's visible that they're gay or not. Sometimes, you know, you can kind of see, oh yeah, they look from the gay community, so you would know. But there are always 10% of us out there. So bear that in mind when delivering any services or being in any groups of people. The statement, services not known to be accessible are assumed to be inaccessible. In order to become truly accessible, organisations must make their position known. So when we talk about supporting the community and when we think about, you know, the slides that are coming up ahead, it's not just about putting a rainbow flag in your window. It's not just about putting a flag outside your building. It's not just about delivering one cultural awareness training session and then forgetting that you might need to do a refresher. It's about making a statement about how you support our community. Now, you know, people say, oh, rainbow stickers, they're great. It shows visibility and it makes it a safe space. Yes, the rainbow stickers are fantastic. And, you know, there's quite a few different rainbows out there. You've got your original flag, which, you know, came about in 1978. That came from what was the pink triangle in the black square that was taken from World War II. So there was a change we didn't want to associate with what that flag meant anymore because it was used against us. So Harvey Milk went to an artist and said, well, let's design something that's beautiful and lovely that represents our community. So that original flag, which has a meaning, all the different colours have meanings to our community. It's not just some pretty colours stuck together. You know, there's sunshine, there's love, there's, you know, all different things that are within that rainbow flag. you know, it's not just about that. Or you may be choosing the Progress flag or the Philadelphia flag. The Philadelphia's got the black and the brown that came about in 2017, and then the Progress flag a couple of years later with the trans and the black and brown triangle within that. So it's not just about showing, you know, we talk about making your position known. It's not just about showing that rainbow. It's not just about having a little brooch on your lanyard or whatever it is and saying that you've had the training. It's about being our ally. It's about standing up for us. It's about knowing about how the intersectionality and the intricacies of our community and standing up for us with us. You know, I heard earlier in, you know, a presentation, nothing about us without us. Always involve us, always ask us, and you know, stay strong, steadfast, and support us in the work that you do. So a little bit about research. The slides will be available so you can actually find some of these studies and bits of research. Ashley will hopefully share that around with everyone. LGBTI individuals are more likely to have had negative experiences with healthcare systems, particularly individuals with intersecting identities, such as queer and trans Indigenous individuals or people of colour, QTPOC, so that's queer, trans, intersex person of colour, which can result in poor general health, decreased access to health facilities, diminished quality of health services, becoming disengaged and not returning for service, and being underscreened for a variety of sexual health conditions. Quite a full-on statement. As a result of minority stress, discrimination, isolation, and collective trauma, including experiences of discrimination, which there are every day for us sometimes, and exclusion, the LGBTI+ community experiences poorer mental health and physical health and well-being outcomes when compared to heterosexual peers. Very true. While a majority, 76% of LGBTI+ people believe it is important to talk with health professionals about gender, sexuality, and intersex status, only 46% have had a good experience doing so. What a statistic, only half. Over half, 55% of LGBTI+ people have felt uncomfortable disclosing their sexual orientation in a clinical healthcare setting. At least half of these reported having been refused a service of some kind on the basis of their sexual orientation, gender identity, and/or intersex status. Again, high percentage. The major barriers to better health outcomes for the LGBTI+ community is fear of discrimination, fear of privacy breaches, and personal safety. So those three things, discrimination, fear of privacy, and personal safety. Whenever I enter a health service, I don't particularly look for the rainbow flag. I don't particularly look for anything really that's, you know, I might have a look to see whether there's resources in the resource section to see whether there's anything queer friendly. Usually there isn't. I would say 90% of the time there isn't anything for the queer community in terms of what support services they can access. But definitely when I'm sitting in front of a doctor for the first time, a nurse, any health practitioner, I am concerned about sharing my sexuality and anything to do with that side of me, because sometimes it doesn't really land well. And also I feel like I have to educate them in terms of my sexual preferences, which is not really what I went there for. So just a few stats really to kind of have a think about what our community experiences. So what is the community concerned about in terms of health considerations? There's a couple of, down the bottom of the page there, you'll see a couple of little screenshots that as part of my work, I sit on a lot of online platforms, talk to community. I'm in front of community quite a lot. These are very, very recent. I get these questions every week from community members going, where do I access a GP? Where's a safe GP? Who will understand my needs? Who will listen? Who won't discriminate? Please, where do I go? I'm new to Bendigo, or I'm new to Kerrang, or I'm new to wherever. Can you help me out? So this is a very, very frequent question. So we are concerned about whether health practitioners will be competent and know the answers to my questions. Will they understand my unique health needs? Is this health practitioner LGBTI friendly? And will their clinic be a safe space for me? Will I have to explain myself again? Will my details and information be safe? What else are we concerned about? There is concerns about being treated respectfully. That's one of the key barriers to LGBTI people accessing health services. LGBTI young people who have questions related to their sexual orientation and or gender identity can be fearful about disclosing same-sex attraction, sex and gender diversity to their GP due to stigma, discrimination and perceived assumptions. Generally, these perceived assumptions, we live in a very heteronormative world, are about gender and sexual identity. So somebody could present to the clinic, you may perceive them as being of the female or male gender, and you refer to them as a female or male, but you may get that wrong. The sex of a partner. I've been many, many times sat in front of health practitioners where they've asked me if I'm sexually active and they presume that my partner's male. I don't think, out of all the times that I've been to GPs in my life, and I'm in my 40s now, I have probably sat in at a doctor's surgery twice and they've known, or they've asked me, which is a nice breath of fresh air. It makes me feel seen, it makes me feel heard. When they presume that I'm with a male, doesn't really land hugely well and doesn't give me confidence in the rest of the session that I'm going to have with them. Relationship characteristics. You may presume that someone is monogamous, single, has a partner, or is polyamorous. You tend to presume that they have one partner. That might not be the case. Sexual practices, e.g. assuming that all gay identified young men engage in anal sex, they may not. And sexual desire, including not acknowledging asexuality. LGBTI people have a range of specific and unique health needs, and we talked about this before. You might be sitting there thinking, what are these unique health needs, and how can I best support someone from the community better? Providing a safe and appropriate evidence-based healthcare is critical. When we talk about safe space, it's about having those brochures in your wait room. It's about having the posters up. It is sometimes about the rainbow stickers. It's about your staff being competent and trained. So your staff having that confidence to talk to a member of community, to understand what intersectionality might be occurring for them, to understand issues about hormone replacement therapy, family violence, sexual preferences, partners, anything like that. So it's about staff being able to have conversations around that. It also is critical, if you understand how to support community, you will be reducing the instances of mental health. We talked about community having higher rates of mental health. And if you are obviously have a welcoming space, you're improving the overall health and well-being outcomes for community. You are creating safety. We are used to being in very unsafe spaces. We really sometimes have to look in a pub before we go in there. Will this be a safe space for me? Can I put my arm around my partner? Is there somewhere where I can be safe, or where I may or may not get verbally abused? So when you create that safe space, you're improving access. And that's a continual thing. Our community needs change in time. So it's about assessing what that space looks like. It's about consulting with organisations like ourselves. It's about perhaps engaging with community leaders that are in the area. I know very, many leaders that are doing great work in spaces, and it's about having a conversation with them. What does this look like, and how can we improve it? If you do a few of these things, Our community will not be lost to care. We will want to come to health spaces. We will want to engage with health specialists, and we will want to get our needs met. Just off the top of my head, in terms of cervical screening and lesbian women, the numbers are very, very low. And why? Look, I think part of that is because lesbian women feel they don't need to get cervical screens, but also some lesbian women don't want to talk about cervical screens and don't want to go to doctors about cervical screens because there's that presumption there that they won't understand about their relationship. However, research in Australia shows that LGBTI people often perceive that health professionals are homophobic, support heterosexuality, lack knowledge, misunderstand LGBTI+ people, have turned people away, lack regard for patient confidentiality, or lack relevant psychosexual training. Some of these people also reported concerns regarding discontinuity of care and inappropriate referrals. The 2021 Private Lives 3 survey specifically identified that out of a range of health services, mainstream medical clinics had the lowest proportion of participants who felt that their sexual orientation or gender identity was very or extremely respected. And I've put there in bold, GPs community health play a central role in helping to reduce such issues and achieve these outcomes. So when I talk about intersectionality, I guess I want to throw it out there again to the audience who I can't see. Again, Ashley, hopefully you can help me with this. What do we mean by intersectionality? What could an LGBTI+ person, consumer be facing? So what is it? What if you have somebody that's come to your wait room or they've presented in clinic for a cervical screen, they've identified that they're LGBTI+, what pops into your head that could be part of what's presenting here or could be part of their makeup? Any ideas? Throw out there.
Queer and Aboriginal disability?
Yes. Any more?
Class?
Class, yeah.
Age?
Yeah.
POC, person of colour, I'm assuming that is. Mental health issues?
Yeah. Brilliant, some good ones there. So let's have a look.
Trans, living regionally, cultural needs?
Yeah. Cultural, definitely. The Indigenous, chronic illness. Indigenous community is very hidden. It's very...
Fear of speculum exam.
What's that one?
A fear of the speculum exam.
Yes.
The cervical screen.
Yep. Are you going to use a small speculum or the large one? Is always what's going on in my head. Homeless, yes.
Finances, alcohol and other drug problems.
Yeah.
Trauma.
Yeah.
Experience of violence.
Yes.
Questioning identity.
Yes. I know I have some queer, I can tell I have some queers in the room. There's some really good ones there. I'm sure is that Damien throwing those out there?
Well, someone's laughing at that. Damien, it is Damien.
Excellent, I love it. Thanks, Damien. So here we go. Intersectional experience, some really, really great ones there. We've talked about disability, homelessness, mental health and AOD. There could be the intersectionality of the intersex, the gender and their sexual orientation, their sexual preference. They could be a young person and someone who is an older member of the community, and that will look different. What presents as a young person of the community who, and an older person has had a lot more disadvantage. They've had to go through a lot more in terms of coming out, a lot more in terms of perhaps feeling comfortable with themselves. So you'll have that difference there as well. You'll have community members that are people of faith, family violence, as we've already said, lesbian, gay, First Nations, and people of colour, TGD, and sex work. So what you may just have in front of you is a lesbian person from the community. Behind that, there is layers of that onion, is how did that person get to that seat to be with you that day? You know, what is their coming out story? What, you know, and sometimes that it can be a positive or a negative, and could have shaped the lens that they wear throughout their life about coming out. And coming out is something that we have to do every day. So there's a lot of different things. There's a lot of intersections. There's a lot of intricacies there with community, and it's not always clear cut about how to support that person. And what I would say is, you know, build that relationship, talk to that person in front of you, and give them the space if they want to share, you know, where they're coming from when you're providing that service. So I've got a case study or two. Again, I'll call out to you, Ash, for a hand. I'm making you work hard today, Ash. Sorry. Our first case study, Susie has turned up to the health clinic with her partner, Jake. When they approach reception, Susie is asked to fill in a form in preparation for her appointment. When detailing her next of kin, there is no option for Jake's gender identity. Susie is frustrated by this and makes her feel unseen. She then enters the appointment where the health professional presumes Jake is a male without asking. Jake identifies as transgender. Susie asks for a cervical screen. The health professional turns around and tells Susie that she has a rather small vaginal opening and states that Jake must have a lot of fun with you. Susie is left very unsure and probably freaked out about what to say next. Let's have a discussion. It's quite a tricky one. How could this have been managed in a more positive way, apart from the obvious? Any ideas?
Updating the forms, firstly, someone's mentioned.
Yep.
Ask questions rather than make assumptions.
Yep. Anything else?
Sorry, Claudia, I know it's hard when people can't talk. I'm the in-between. Why is there a gender needed for next of kin? Maybe pronouns would be better.
All right.
Don't comment on body parts inappropriately. Yeah, again, don't make inappropriate comments. Professional language. No judgment of the size of the vagina. How dare the doctor make such a comment? Yeah, that would have been my comment. Health professionals could use their pronouns to introduce themselves so that then they are comfortable to ask their pronouns.
Yep. All very great suggestions.
Someone suggested, shouldn't Susie be having the consult on her own?
Oh, yeah, possibly.
Professional language, pronouns.
Yeah, about asking that person first before we presume. Anything else? How would people expect Susie to be feeling right about now? If you're putting yourself in Susie's shoes.
Violated.
Mm-hmm. Yep. Do you think she'll want to go for a cervical screen again?
Disrespected. Someone else seconding violated. Angry. Nervous for what's coming next. Unsafe.
Yeah.
Unsafe again.
Yeah.
An object.
Mm-hmm.
Disheartened.
Yeah.
Not understood, afraid, paralysed. Absolutely not wanting to engage in screenings in the future.
Yep. There's a lot of feelings there. And as you can understand, you know, there's a lot of community members that do, you know, that sit in front of GPs, nurses, any health practitioners that face this on a very regular basis. And you've called out, I think I have 2, 4, 6, 8, 10 different feelings there that because of that interaction with the health professional, those feelings will also come out in that space. So when we talk about creating safe spaces, when we talk about the forms, when we talk about you know, not presuming gender or sexuality or anything like that, and just making that place a safe space for Susie. Those are the types of things that will avoid Susie feeling like this and avoid, you know, our community not going back to health care spaces. So there's a lot in that one. I have a second one here. Kylie has an appointment to see her gynecologist. She's had severe issues with fibroids for several years with heavy bleeding and wants to request a hysterectomy, age 35. The gynecologist is male and during the appointment challenges Kylie about her request. He asks her whether she is sexually active. She states she is. He continues to tell her that she will want children and can still fall pregnant at 35. Kylie states she does not want children and that there is no possibility of falling pregnant. The gynecologist appears very confused. So my question here is, how can you work? This is another thing as well. You may be in a health space where you're not quite there yet in terms of forms, you're not quite there yet in terms of training, but you are, as maybe an individual, feel quite culturally competent, but some of the people around you may not be. How in this space can you work with staff to help change cultural norms? If you're a nurse in with the gynecologist, what would you do? How would you approach this? How would you be an ally? Open to suggestions, throw that one out there.
That's a story heard time and time again for all women.
Yep.
That's my own comment. I didn't read that. Sorry.
I know that Kylie aged. She decreased in age. She fell. We went through the case study. She's 34. We'll make her 34. How can we be good allies?
That's a tough one. Someone said, as many women have this issue. Yeah, and the gynos will turn them down. Infuriating. Yes. Not sure if it would be better to chastise the doctor immediately or afterwards. Someone said that ask her if she was gay.
Yep. I would probably ask if they're a member of the community rather than asking gay. To say you're a member of the LGBTI community is probably the better language there. She may not identify. Gay is more of a term used in the States. Australia prefers lesbian.
Involving colleagues in conversations about some of the things that you were seeing, case discussions, to normalise this experience in the doctor's eyes.
Great. Great discussion. Sometimes it's difficult to challenge, you know, seniors or people that are kind of have a bit more of a hierarchy within health organisations. But it's good to, you know, have the conversation at staff meetings, maybe bring that up as an issue. I had just yesterday, I was at the dentist and the lady that was giving me the teeth clean, or whatever you call that, lovely lady, told her what I did for a living, and she turned around and said, oh, my mother, just the other day, she's a nurse, was sat in the wait room and this person was crying in the wait room. And I said, oh yeah, you know, what was going on there? And apparently this person identified as from the transgender community had gone into a consult, had been made completely to feel terrible about being from the trans community and was in the wait room crying. And her mum had to console that person for an hour before they could actually leave the space that they were in. So, you know, there is a lot to think about there. We could, you know, sometimes without knowing it, you know, cause further harm. And it's really about educating yourself and knowing what is the right and the wrong thing to say. And just before I go on to the next slide, those two case studies are real because they happened to me. So a little bit of sharing there. I went to the gynecologist and he presumed that I was dating a male. And again, that was the conversation that, no, you want to fall pregnant. I'm sorry, I'm not going to give you a hysterectomy. So again, you know, those two, and the first one, again, the health specialist did turn around to me and commented on the size of my opening and basically told me that guys would have a lot of fun with me. So they left me both a little bit traumatized, I must say. I have worked through that. I'm a pretty confident human and I know how to kind of talk for myself and I'm very health literate. So if you can imagine, Other members of the community that are not so confident, not so health literate, maybe young members of the LGBTQI community, what these instances and what these, what they come up against and how they can feel during these appointments. So how are we accessing safe and appropriate support? A little bit of positivity here. When we need support, when we want to try and find access, health services in regional, rural, remote spaces, where do we go for that support? Usually our peers. I'll probably text my mate up the road, who's your doctor? What was it like? And was it a safe space? Was she or he okay? Do you reckon I can go there? So again, peers, other members of the community. We go online, so there's a lot of support groups such as LGBTQI Bendigo Face Groups, TGD Bendigo, Zoe Bell Gender Collective, Rural Regional Rainbow Network, Transcend Australia. COWAR has the House of Awesome, which is in Macedon Ranges, Way Out Rural and Sexual Diversity Project, and us, Thorn Harbour Country, they ask us a lot. There's also some online LGBT referral platforms, such as DocList, Wombat Plus, and Doctor, and LGBTI media and advertisements in magazines or promotional social media posts. So we do access some support out there. If we don't know where to go, we will get in touch with the community. So if you're thinking about how to advertise your space and how to engage with the community, these are some great platforms. Link in with them and have your service known. What do people expect from healthcare? We talked a little bit about how we go to access healthcare, what we do and don't want to talk about, what our fears are a little bit. So, this slide really is about understanding what it is we need. So minority sexual orientation is regarded as a normal variation. So, we want to be treated just the same as anybody else. An inclusive practice environments that serves to normalise their sexual orientation. Awareness that LGBTI plus people attends the practice. Avoidance of assumptions of heterosexuality or cisnormativity. Attitudes that are openly non-judgmental, accepting and affirming. Knowledge of specific health issues and sensitive, culturally appropriate referral networks. Advocacy and support with issues regarding their sexual orientation, gender identity and or intersex status, and assured confidentiality. Talked a little bit about confidentiality in a couple of the other slides. The community is small. In my work, even though I work across such a large space, some of the people that I work with are my friends. Some of the people that I work with happen to be on my Facebook. Some of the people that I work with, I will bump into on a weekly basis, and we all know each other quite well because we are, whether it's 10% in hundreds, we are a smaller community. So when it comes to creating a safe space for us, just because we are from the community doesn't mean we want our information shared with Tom and Harry down the road. So when we talk about safety around that, some of the community also may not be out. They may be coming to your surgery and stating that they're out, but people in their own community may not know that they're out. So there is a lot around confidentiality of information there as well. This is a video of our health clinic in what was Fitzroy. It's now in 200 Hoddle Street in Abbotsford. We've moved it, but this is an idea of what our STI screen looks like and how we work with community. This was done for Pride Salation, which was a queer online festival that I worked with several other regional festivals with. So there is a bit of a mention of Pride Salation at the end, but this is just to give you an idea of how we work in the STI screening space.
Hi, Murray.
Hi, Ash. How are you?
Good, thanks. How are you?
Good.
Great, Ash. Okay, so I've come in here, I've come into Pronto. What's Pronto?
So Pronto is a peer-led HIV and STI testing service for members of the LGBTIQ community run by the community.
Great. So if I wanted to come in here for a sexual health test and a HIV test, how would that actually happen?
Okay. So if you're not on PrEP, we can offer you rapid HIV testing.
Right.
This service is actually funded for rapid HIV testing and STI screening. So what we will do is we'll collect some blood from your arm, and the blood will cover syphilis and HIV because they're viral infections. And we'll do some throat swab, anal swab, and we'll get some first pass urine, and that will cover bacterial STIs such as chlamydia and gonorrhea.
Okay, and so if thinking about the people watching this and to get to Pronto in Collingwood is probably just a touch too far away, what would you say?
I say go to your local GP and explain to them that you're here for a full sexual health test, and make sure that they do a throat swab and a rectal swab, because most GPs out there don't actually do risk assessment, so therefore they would assume that you're heterosexual, and that is often the case. So those are the two important things that I would stress. Get the blood test, make sure the blood test includes HIV and syphilis, and get an oral or a throat swab, a rectal swab, and a first pass urine test, which will cover chlamydia and gonorrhea.
Great. And so if I wanted to get a HIV test, but it was just not a conversation I wanted to have with my country GP, is there another way without coming to Pronto that I can get that done? Can I get it sent in the mail and do it in the mail? I've heard about that. Can you do that or not?
There's a couple of complications around that, and that's usually because to have some form of rapport and access to a GP service where your blood has been collected, where you can go back to collect the result in case if it were to come back positive, is quite an important thing, because that's not an information that we can relay over the phone or over the mail even. So therefore, I would say shop around. I know it's quite tricky, but find a GP that you feel comfortable with and access your sexual health testing there.
And I guess, of course, if you really wanted to, how often should you get tested? Because it is something that if you were comfortable to speak with your GP about, or you didn't have any options to get on a train and come down to Collingwood, what would you say? Is it every 3 months? Is it every 6 months? Or what's the advice around that?
It depends. If you're in a monogamous relationship with someone, it's recommended you get a test once every 12 months. If you're sexually active, let's just say if you have anywhere more than 5 sexual partners in a month, I would say once every 3 months is what we recommend.
Great. And what kind of numbers are you seeing here at Pronto?
Currently, in terms of numbers, we've always had very regular clients walking through. I think it's quite well established in the queer community that people get tested once every 3 months, which is great.
Yeah.
The queer community is very on top of their sexual health. But in terms of other communities, so there's Melbourne Sexual Health,
right?
That's still running.
Yeah.
And most other GPs are doing sexual health testing as well.
Fantastic. So we're going to wrap it up here, Ash. Is there any last minute sort of advice that you could offer to someone that was perhaps maybe living really far away from a metropolitan area and watching Pride Salation tonight, that you could tell them that actually might be good advice?
Jump into a train and come and see us.
Oh, that's good. Thanks, Ash.
And there we go. That's our Pronto. We have Pronto and Equinox. So they're 2 clinics now that are based at 200 Hoddle Street in Abbotsford. So that's our main headquarters in Melbourne. And they are award-winning clinics. Why are they award-winning? Because we do health differently. So if you have a chance, maybe pop in and see those clinics. Peter Locke is the manager of those clinics, and I'm sure he'll welcome any questions about them. Nearly there. I'm nearly taking up the whole hour. I can't believe it. It's nearly 3:20. What does affirmative healthcare look like? We've talked a little bit about that throughout the presentation today, but we are talking about the use of respectful language and terminology, pronouns, talking about sexual orientation, sexual identity, gender, things like that. Use questions which are gender neutral and non-discriminatory, such as, do you have a partner, rather than do you have a husband, wife? Be curious but respectful. Try not to ask direct questions. Somebody may not want to divulge their personal information, may not be ready, but give them that space. They will open up if they want to. There is a lot of trauma there, and they haven't had very great experiences with health services, so just be mindful of that. Affirm identity and experiences. Celebrate milestones for the person. Assess your own privilege and experience in the world. You're very lucky, most of you, to be able to go out there and not have to tell people that you're from the community. I have to, unfortunately, still do that in certain circumstances. I wish I hadn't, but I still do. So just remind yourself of that privilege of your heteronormativity. Understand oppression and discrimination in terms of our community. We've talked a little bit about, the trauma that all that and coming out and experiencing discrimination can cause, and don't project your own personal beliefs or values. Some referral pathways here. There's a lot of services out there that can support regional, rural, remote community, including Thorn Harbour Country. There is no excuse to not refer people to services. There are hundreds of services out there, hundreds of services offering very different things, lots of specialities. For instance, Switchboard has a helpline which is open for quite a lengthy period of time if someone wants to talk on the phone. You've got our service, for instance, that is not just about sexual health. We're also about mental, physical and social. So there are a lot of things out there for the community. Get to know that, do a Google, type it in, see what's in Kerang, see what's in Bort, see what's in Swan Hill, and refer them to those services. Have those on hand, stick them on a bit of paper on your desk, and have those ready for community. And that is about it. I think I've left a tiny bit of time for questions. Those are my details. If you love this prezzo, love us on Facebook, check out our website, thornharbourhealth.org. We are an ever-changing organisation. We've just started to do national work. We are growing, not as quickly as my stomach during COVID, but we are growing. So always check out our services if you go into the main site, on the right-hand side, you'd have everything that we do. There's heaps of groups, there's heaps of peer support, there's family violence, there's therapy, there's health promotion, there's so much stuff. There's, financial planning, the PLC that offers support for people that are in the older community, there's food pantry, you name it, we've probably got it. So get in touch with us, get in touch with our beautiful staff down in Melbourne. And if you want to partner or have me out or have me involved in any of your work, my arms are open. Thank you.
Thanks so much for that, Claudia. That was fabulous. And I saw some people saying in the chat before, and I will reiterate, the sharing of your own stories, sharing personal stories can be quite powerful. So thank you for that.
No worries.
Yes, lots of thank yous coming through. Here's a question. Is there an age criteria to accessing the services?
Yes, look, usually we are over 18. There are some services at Thorn Harbour Country that do under 18, and we are looking to do under 18 therapeutic support. So just keep your eyes open. If you do have a referral, always let me know or give the head office a call. We could be doing under 18 soon.
Great. Almost follow up. Do you get invited to do work in schools?
Good question. Look, actually, I've been in the role now for 2 years, and I've just started to get invites. I think after the Safe Schools debacle, it kind of went quiet a bit, and I've now been invited to present. I was invited to do some work with Chafey High in Mildura. I'm always very excited to do work in schools, and I do deliver Health Smarts, which is an LGBTI sex ed workshop. We call it Wellbeing, but we cover a lot of sex ed in there. So I'm definitely open to doing work in schools.
Right. Is there a plan to expand into other regional areas across Victoria?
I would love to. I am pushing hard that I'm not just Loddon Mallee. Some of our city services do cover Gippsland. Technically, we're funded, Thorn Harbour Country, under the BBVSDI work. We're funded for Loddon Mallee, but some of our Melbourne-based work, other project managers, team leaders do work in areas like Gippsland and stuff like that. So we are across the state. But it might not just sit under Thorn Harbour Country as yet.
Okay, so if people are here and they're from an area outside your funded area, would you still recommend getting in touch? And
yes, absolutely. Yeah. Look, there's always, if it's not myself that can do the work, there's always a colleague that can come out. The family violence is statewide, the therapeutic is statewide, so there will be team members that can come to you for sure.
Yeah, great. Thank you. I hope that once you stop sharing your screen, Claudia, later you'll get a chance to read all these lovely comments.
Hopefully I've got a lovely comment about my hair as I go grey.
And you said you were happy for these slides to be shared, Claudia.
Yes, absolutely, yes.
But I will just remind people as well that this session is being recorded and it will be made available on our website for you to refer to in the future. Oh, here we go. Sorry, here's a Q&A. Yeah, someone's commenting working at RED. I always forget what it stands for, but you would know, Claudia, with sex workers.
Yes, sex workers, yep.
Yep. Someone saying that we work with sex workers and are looking at a regional project, and it would be great to connect. So yes, your email address is there on the screen now?
Yes, I've had a conversation with someone. I forget his name, but he did chat to me about coming up to Bendigo and hopefully sitting in our space. So that would be lovely. Push that forward. I would love to have you guys come and share a space with us.
Great. So Claudia's email address is on the screen. So feel free to bombard her and glean from her expertise.
Nice things. Don't work me too hard. There's only me.
If there are no more questions, we are having a break, another break. Good. It's a good chance to check your emails, go outside, have a cup of tea. Yes, and then we do have one lucky last session with Jenny Walsh, and Jenny's fabulous to listen to, so please come back and join us at 4 for Jenny's presentation. Thanks again, Claudia.
Thank you.
Bye.
Bye.
Good afternoon. Welcome to the last session of the day. After an excellent day that we've all had together, I would like to introduce educator and researcher Jenny Walsh. Jenny is going to be presenting on a comprehensive, inclusive approach to sexuality health promotion for young people. Again, please put your questions in the Q&A and Jenny will answer those if she has time. Thank you so much, Jenny.
Hello, everyone. My name's Jenny Walsh, and I have a long history as a sexuality education person. I started as a primary school teacher and then ended up working in community health, doing health promotion projects around sexual health, and working with young people, schools, and in the olden days, we used to call it people from non-English speaking backgrounds in 2 days a week. So I'm going to be talking with you today about what the research says about what works in health promotion for young people. And I won't talk much about parents today. There's such a lot to cover. But I thought I'd wake you all up for this last session and ask you to reply in the chat box, what is this? What is it? What do you think it was used for? When might it have been made? Nice one, Kylie. It might be. Oh, no, I don't think it is. No, it's not. I tell you what it is. It's amazing. I wish I had it here to hold. It is from the 1800s. Yeah. Well, it's not as ancient as you'd think, really. 1800s, China. And it was something known as a trunk bottom. And the parents, when their daughter was getting married, would put it in the bottom of her dowry chest or her trunk. And it was, someone said, you know, it was a sex ed resource. And they're not entirely sure, but they think that's what it was. It was only given to the daughters on the eve of her wedding. So it's an ivory model of a couple embracing, and they'd keep it hidden from the children until just before they were getting married. So there are so many directions we could take a conversation about looking at objects like this and thinking about how sex ed was done in the past, if it's changed very much for the better or worse. What would be some words that you would think of when you look at that sculpture, or that couple, I should say, to describe the couple? Steve. Yeah. Yeah. So some of the ways I've used this conversation before are to initiate conversation in parent groups about the parent's role in teaching sex. Oh, someone says I can't stop looking at the tiny feet. Yes, in fact, they are bound feet, yes. And so that was a practice related to being an upper class woman, and of course that was considered to be a sign of beauty back then. So you could take it in that direction too, right, about changing expectations, assumptions about what is beautiful, about impositions on people's bodies, changing our bodies, which we do all the time. Teaching how to have sex. I have to say that a lot of you have, when I look at that, I think, it sort of looks, it could be promising. I mean, it's actually showing people having sex, and their faces to me look kind of happy when I can see them on my picture. And the other sorts of conversations that we could have might be, do you consider that it's, say, pornographic or not? What if they'd been upside down to each other? Or what if it was really clear that maybe they were two women or two men? Would our perception of whether it's pornographic change then, depending on what kind of sex act is being represented and taught by parent to child? So the simple point I want to make, and it's sort of accidental to all of the other speakers from today, is to help reinforce with young people that the constructed nature of gender roles, norms, and how we define pornography, as someone says, or all our definitions, they change over time. So these things aren't all set in stone. And in fact, one could suggest that the Chinese government's position on sex and sexuality has changed very much in the last, say, 80 years, but depending on, very different to what it was perhaps in the early 1800s. So I think the other point I want to make is that difference and diversity in the groups that we work with is inevitable. And the other thing that's changed over time is our construction of what sexuality education is and our understanding of what effective sexuality education is as well. The definition of best practice sex ed has changed, and you would have heard the word and used the word probably lately, comprehensive sexuality education. And that's indicating a shift from more the expectation of changing behaviours and limiting diseases to a rights-based approach, and also about focusing on people's agency, as well as sex and reproductive health info, gender equality and power, and positive sexuality and respectful relationships. There are varying degrees of focus on those 4 elements, depending on who you're talking to. I guess one of the things I'm a little bit worried about at the moment is because, of course, we understand that gender is a key driver in violence against women and children, and also in homophobic and transphobic behaviours. I'm a bit worried that we're leaving out number 4 of those 4, if you can remember them, which was the positive. So certainly in time-restricted classrooms, what I'm seeing is, oh my God, we've got to talk about consent. So we're jumping straight to talking about sexual assault as a starting point. And it would always be my preference that we start from talking about what people want and what's important to them, rather than jumping in with where we think they need to be. I think too that starting, not just me, but the evidence says that starting from a positive place helps us to get to where we want to be, right? So when I'm talking with parents, the first question that I ask them is not these are all the dangers, but what do you want for your child? What do you hope for them? Do you hope that they'll be in love when they have sex for the first time, that they're sober, that they're respectful of the person that they're with, that they're married, and so on? What do you want for them? And so what are the sorts of things that we might need to think about that drive the conversations and inform the conversations that we have with young people? If we're just thinking about stopping STIs, then we're not going to talk about the stuff that helps them to make that happen. So I think what I'm seeing too in some settings is that because consent and the law, because it's a knowledge-based thing, it's easier for untrained people to talk about rather than all these other things about challenging gender stereotypes. Those kinds of understandings fall under the umbrella of transformative education, and you don't get that from fact-based learning only. It requires a bunch of experiences so that you have time to reflect and to think about what it means for you in your community, in your culture. I think one of the things that I heard today, working with culturally and linguistically diverse groups, was, nothing, what is it? Nothing without it, nothing for us without us. Anyway, you know what I mean. And it's so important, again, with the consent stuff, when we were first seeing all the newspaper coverage of it earlier this year, experiences in private schools. There was one Sydney Girls College private school, and the principal was saying that she went to have a meeting with the year 11 and 12 girls to discuss what she was hearing in the papers. And she wanted to learn more about it and what was going on for them and how she might make a difference. Well, her expectation was she would learn that the parents were being lax in their monitoring of the young women, and that alcohol was to blame. But she was shocked by how many stories the young women had, and what they were talking about was the pressure on them at weekend parties, and that they felt that they were almost being hunted, encouraged to drink a lot of alcohol, and targeted for sex. So I'm so pleased that she went to talk with the students about what was happening for them and what they'd like to learn more about. But I confess I did think too that best practice in education as well as in health promotion is to do a needs assessment, right? So if they were doing best practice sexuality education, they would be embedding activities and safe ways to find out what's important, what is real life like, and what are their priorities, rather than, presumably they were doing sex ed. I don't know what they were doing if they didn't find out that stuff. So I think another example of that might be, I was lucky enough to be engaged by Family Planning Victoria last year to develop resources for international students, and they are quite vulnerable. Some of them are very lonely. They are experiencing higher rates of unplanned pregnancy and STIs, and potentially sexual assault. There's a lot of structural factors playing against them about their willingness to come out and say they've got a problem because they don't want to be sent home. And so my job was to find a way to bring them relevant education. Now, if I had come and poured on top of them a whole bunch of STI information, that would have had about zilch effect. In fact, I suspect it would have been harming, because you raise their fear, but not their capacity to do anything, let alone that their English isn't there, for many of them, English isn't their first language. So instead, we ran focus groups where we talked about what's exciting to you about coming to Australia? What are you looking forward to? How do you learn about sex and relationships in your home country? How would it be different here? So what they ended up talking about, they chose photos that represented sex, family, love, relationships, that represented them here in Australia and in their home country, and they were very different. The ones from their home country, they always chose photos that showed a large family group looking around at them with great intensity. And the ones from Australia had rainbow colours, hope, adventure, excitement, oh, thanks, Cardi, that's the link in there. All those things that they were looking forward to. They were looking forward to adventure. So they were looking forward to getting to know people. So we called that program Dating in Australia. We made videos that interviewed them talking about their solutions and their barriers to sex health based on the things that they cared about. So I think that every new group that we go to is a new culture in a sense, and it's really important to start with that process. So, yeah, and one more little thing I would say is that if, as health promoters, you are supporting schools, which is awesome, to deliver sexuality education, because it's such a broad subject, do keep in mind that I think that the main thing that we're missing at the moment is, a good teacher is looking to teach about knowledge, attitudes, and skills, usually relationship skills, communication skills, but also your skill in being a critical observer of the world around you and reflecting on whether that is true or set in concrete, hence the couple at the start about having a sense of history, I guess, that's so useful. What is kind of missing is the stuff around my heart, my values, my discussion, my differences of opinion, and so on. And again, I would reiterate that we need to learn how to manage peaceful disagreement in our classrooms as well as outside our classrooms, because in fact, it's that fear of managing, you know, the uproar that's stopping us from talking about what might be termed sensitive topics, or has often been used as an excuse or genuine concern about talking about diverse sexual identities and diverse gender identities. And gender identities is the thing right now, I think, that worries people, and they tend to just sort of forget about. So the next thing I'd like to talk about is just to reflect on that some children and young people miss out more than others in terms of our sexual health promotion campaigns and our sexual health education, in schools-based education as well. And if we needed any further proof of that, then COVID provided it, that some groups, those groups that we sort of could have predicted, right, experience more separation from the existing systems that are supposed to be designed to support all of us and help us through this stuff. And confinement, of course, when we think about safety at home and gender-based violence, then confinement at home, we're assuming, is putting more children, adolescents, particularly young women and girls, at increased risk of sexual abuse and exploitation. And we know, of course, that some young people will be experiencing mental health issues, loneliness, dating problems, and stress in relation to trying to maintain their study, or just not getting out of the house, and not connecting with their buddies in real life, which is so sustaining. So we need to reach out more than we have in the past. Well, I'm speaking for myself, right? To continue to reach the those more vulnerable young people. I would say, because I've written quite a few national resources, usually I'm funded to do a mainstream resource. And I think if I had the opportunity, I'd do it differently. I've always tried to be inclusive, and I've always tried to use activities that enable people to bring themselves into the room, if you know what I mean, tell their own stories, reflect on their own experience. But I think certainly I could do better, and particularly for young people with disabilities, yeah. Right, oh, now, before I go any further, there's something I want to share with you. I'll put it in the chat. If you do want to, here's two resources. So this great resource that's called Sex and History, that I took that, that image from, have a look at that. There's two separate ones. One's sort of about sex and relationships education broadly, and one specifically was created for LGBT History Month in the UK. And you'll get lots of great ideas from there if you were working with groups of young people. Okay, now the second thing that I'm drawing your attention to, though, is this international technical guidance. It is really good. I only came across it last week. Excuse me. It addresses, it's called non-formal education, and really it's kind of charting that there's those people that miss out on school. We need to find ways to reach them. And, you know, my son has some learning disabilities, and so we were trying different forms of schooling for him, and we had to go at, what do you call it? Not School of the Air, I'm so old, you know, like remote learning. And we went to their open day up here at Thornbury, and so many trans young people up there, right? I should have recognised that there'd be a larger proportion of young people there who weren't going to mainstream schooling for maybe not because of their identity, but one would presume that it had something to do with it. So anyway, that guidance will talk about all kinds of disability, or at least such as, you know, the difference between autism spectrum disorder, intellectual disability, physical disabilities, and what those young people's needs might be, as well as young people who inject drugs, young people who are sex workers, and so on. So all the things we need to think about to reach the vulnerable, and outlines the gold standard steps we need to take in designing our programs for them. So, right. I guess in summary, I heard a story recently. It's from Victoria, but I've changed details. And I think it really captures what we need to do, because, no, I won't preempt it. So here's the story. So I was talking with a school nurse from a regional area, and she said that a local GP had a number of young people come into the surgery with anal tearing from penis-anus sex. And the GP was worried that these young people, that it was coercive sex. That's all the information I have, right? Apart from part 2 of this story, which is that the GP then approached the local school and said, look, I'm worried about the education that these young people are getting. I think you need to start talking about something. I'm not quite sure what the expectation was. And all of the health PE teachers in that school said, no way, we are not touching that with a barge pole. So the school nurse went back to the GP and said, and the GP offered actually to come and talk to the young people, and then sort of things happened and it never happened, right? So here's some questions for us. Could we talk about having anal sex safely? Could teachers talk about that? Or is it one of us health promotion folk that might be able to provide that education? The gender of the people that had the anal tears were all young women. And it got me to wondering if it had been a young man who'd been having anal sex, would he have felt comfortable to access health services? Would he have been certain of his confidentiality being maintained? Would the response have been perhaps even more emphatic, and even more emphatic no, if you were going to talk about anal sex between two people with penises in a school classroom? Would people, can those young people, whatever their gender identity, expect praise for turning up to get medical support? Would they get praise and support for, or the opportunity to reflect on if it was coercive and what a positive sexual experience could and should look like? Is their education challenging those expectations of pleasing him? The thing I think that people are having the most trouble including in their education, so I said before, it's sort of about the components of education or the messaging, which covers the different kinds of knowing, right? Actually, I didn't mention feelings. I'll chuck that into feelings, knowledge, attitudes, and so on. But one of the research is telling us, and this is what we've learned, is that it's essential to address gender. And that is the thing that people are having, I think, the most difficulty with. So to talk about, to challenge gender norms is something that they're quite nervous about. And I wonder about that. And some of those questions came up in the groups earlier about how we talk about that. I think, you know, there are ways of putting it on the table for discussion that are safe and that, you know, require us to listen. And then to say, well, this is kind of what the research is saying. How would you want to do it? What do you feel comfortable with? So when it comes to health promotion and sexual health education, sexuality education, or whatever we call it these days, there is, and I'm currently engaged in revising the Australian curriculum, health promotion, health PE curriculum, which is mostly, unfortunately, where sexuality education sits, to address gender-based violence. And there's a real, what I still see is a real preponderance to focus on the importance of teaching you skills and your capacity to change, and without adding that other element, which is understanding that, hey, it's not you, it's them, you know, that it's not you, you're not being rejected because you're different. You're being rejected because they can't deal with difference and they're frightened of it. You are fine. You know, when we were first talking about consent and people were using the teen consent video, which, as people who know me know, I have really great reservations about. And the reason I'm unhappy about it with it is for this reason. It asserts that consent is simple, and it's not. Because if you thought for a moment about how difficult and awkward it is as a young person in a small town or wherever to potentially make a fool of themselves by saying no to something that everybody else says yes to, and all those social implications, it ain't simple. And I think all it takes is the time to reflect on what makes things in real life difficult for all of our messaging to make them effective. So in terms of health promotion and education, there are two things we need to do. One is that the research says that whilst it is super powerful to go through to teach individuals about personal social skills and so on, and to talk to them about changing, learning, understanding about equality of gender and sexual diversity and racism, we also have to look at the big picture. And so in health promotion terms, it might be that the best thing you can do is to lobby for getting teachers excellent training, or the best thing that you can do is to lobby the state or the federal government to create, you know, inclusive education, or to support that awesome doctor who was so concerned about the well-being of young people, who came along. Clearly, I would say that school nurses spent time in developing relationships with the services. So it's only the combination of access to services and you know, information, education, thinking through stuff that makes a difference in comprehensive sexuality programs. Okay. Any questions? We've got one already. Has the language shifted from people being vulnerable to people being targeted by individuals who use violence? I don't know, Rose. Can anyone else answer that? And I reckon you'd be right, though. it's not you aren't vulnerable, you aren't inherently vulnerable, are you? You are vulnerable because of your position in society. Thank you. Oh, thanks, Alex. Marginalised instead of vulnerable. Yeah, great. Thank you. It's learning all the time, right? Now, there's a very long one here. Do I provide RSE to Indigenous Australian young people? No, I don't. If so, do you have any advice for delivering RSE that doesn't reinforce colonial ideals? Only that in talking about, no, I don't have any good resources to tell you about. There's some beautiful resources, online resources for young people. Can't remember them right now, but I don't think even they address decolonising sex. But I think, I reckon, Rhiannon, that something like that object-based learning would work beautifully, because when I worked with VACCHO to write a parent guide, we didn't have an object in a sense. Well, we did have an object, because I'd written for West WA Health some years ago a resource called Talk Soon, Talk Often, and it's for parents on talking to their children about sex. And VACCHO had a really positive experience of parents. Oh, thank you. Thanks, Tanya. Yeah, write them in if you've got the good resources. And so Peter Waples-Crowe and Kylie Stevens from CERSH and I talked about, wouldn't it be awesome to have a parent resource that celebrates Indigenous families and what's important to them. And so in WA, my colleague, Dr. Sue Dyson, had run large focus groups, series of focus groups with parents saying, what do you want to know about? And then we kind of did something similar. Oh, thanks, Alison. Vulnerable, not marginalised. I'll put that in my homework to figure out. What the WA research found was that the parents were talking about, how do I share my values with my kids? When's the right age to start talking with them? But when we talked with Aboriginal families, they talked about how much pride they had in their community and how important, when we talked with young people, they talked about how important, stepping into being a community member and someone to guide and support the young ones was. And they talked about, beautiful stories from their family members outside of a mother or father. And they talked a lot about humour as well. And so if you think of creating a resource as having pillars or themes, well, the pillars and themes were different in the Yarn Soon, Yarn Often resource than they were for Talk Soon, Talk Often. And I don't know if Anne from VACCHO talked about it earlier. I didn't see her whole presentation. So hopefully that'll be coming out later in the year. And really, it's just telling people's beautiful stories about how they do it and how they raise sexually healthy kids. So, celebrating people's own solutions is kind of the secret, isn't it? Any more questions? So people are talking about, oh yeah, I forgot all about Young Deadly Free. Thank you, Alison. And VACCHO, if you look up VACCHO's website, obviously, and there's another awesome resource called, hold on, I'm going to Google it. read that. It's really good. It's written for people that work with, it's a little bit old now, but I really love it. And because it's an Indigenous word, it doesn't stick in my head. Okay. It's something like a word, I think, that means deep listening. And it was brought out with, I think, VACCHO and the National Aboriginal Community Controlled Organisations, and ASHM, the Australian Sexual Health or HIV, organisation. Okay, well, if you don't have any more questions, then I'm going to say thank you so much. What do you think of the Freris model of consent? Yeah, I like it. Yeah, I think it's good. The Freris is, I've forgotten what it stands for. Yeah, it's fine. As long as it goes hand in hand with thinking about, structural impediments to my power, the power that I have and the capacity that I have. Yeah, and my own solutions as well. Yeah, Alex. Listen, anal sex is, if you're doing something called sex, oh, thanks, Dave, good on you. There's the Freris acronym. Anal sex is sex, like, I mean, that's heterosexism, right? That, and it is saying that one kind of penetrative sex is okay and normal to talk about and the other one isn't. Yay, that's it. Giardi, is that how you say it, Rhiannon? I really like it. Yeah. So have a look at that one. Okay. I'm a contractor, so I do develop resources and I provide professional learning and parent education. And my business is called the Hum Academy, trying to put a positive spin on sex, And I'm dedicated to being inclusive and trying my hardest and learning all the time. And the next project, hopefully, that I'll be doing is working in Muslim communities, I hope, with under the leadership of Muslim leaders. So, so much to learn and keep learning and risk making mistakes. Okay, thanks, friends. See you later.
Thanks, Jenny, for your presentation. Yeah, thanks for coming through in the chat. And Jenny, I'll just remind you, if you are logging off now, just turn your camera off and you'll disappear from the screen, unless you want to stay on the screen and say anything else. No, there you go, great. That comes to the end of our professional development day. I hope that all of you enjoyed it as much as I did and that you learned something. I'm sure that there will be continuing conversations between you and your colleagues about the content. Again, the recording will be made available if you would like to watch or refer someone else to watch. Oh, sorry, I thought I heard someone's voice. That's okay. There will be an email sent out with an evaluation link. If you're able to fill that out, that would be great. It helps us to inform future professional development opportunities. That is all that I would like to say. Thanks again to all of our presenters. They were fabulous, and thank you to everyone working behind the scenes, making this day possible. And lots of things coming through in the chat. That's fabulous. I'm glad that everyone enjoyed it. Take care of yourselves, and we will see you next time. Thank you. Bye.